Thank you to all of you for joining. This is the second ever Southwest Critical Care Network Forum. We did this last year. It was quite popular, and so we thought we'd do it again. The intention is just to have a free, easily accessible clinical forum whereby you can hear from some experts and have plenty of opportunity for discussion. So unlike the majority of sort of talks or seminars that you may go to, we've factored in about 20 minutes for discussion with each speaker. So there's an opportunity for you to question them and have a discussion with them about how what they've spoken about may apply to you and may apply to the patients that you look after. So just, if I may, just a quick word about the network and what the network does, because I appreciate that a lot of you may be unfamiliar with what the Critical Care Network is. So we are essentially an entity which links NHS England with the critical care units in the Southwest, and we support units in delivering and developing the quality standards which you all try very hard to deliver on a day-to-day basis. So there are some national metrics which your unit leads and matrons will be working hard to try and achieve, and our role is to try and support your units within your trust to try and deliver those. We also represent all of you not only regionally but nationally as well, and part of our role is to try and shout the needs of the Southwest at a national level to try and support you all in looking after your patients in the way that you would like. So that's the role of the Southwest Critical Care Network. For those of you that haven't met me, my name's Andy Giorgio. I am Clinical Director for the Southwest Critical Care Network, and I work with a team of people. Some of whom you're going to meet today. So David Kane, Denise Axelson, Graham Brandt, and Sarah Miller. And I am also a consultant in anaesthesia and critical care or intensive care at the RUH in Bath. So we've got some great speakers lined up today. I'm afraid there's been a change of the programme. Our first speaker, who is Nitin Arora, has unfortunately had to go back to India because his mum has been taken ill. She's in intensive care, so he's had to go back. So our thoughts are with him, and I hope that things work out well for you there, Nitin. So we've got speakers which cover medicine, allied health care professionals, and nursing as well. And we've got some great speakers lined up for you. The meeting's going to be recorded. I hope that's okay with you all. It's going to be then available on our website, and we'll circulate the details of that throughout the course of the meeting. If you're able to just put the link to our website on there, Sarah, that would be very helpful. So before we kick off, just looking through the attendees, lots of attendees from all over the region. Thanks very much for joining us. Any questions or queries on any of that just before we get going? Great, okay. So we're slightly early, but I guess makes sense just to kick off. So in Nitin's place, we have very kindly had David Kane step in. David is a consultant in anaesthesia and intensive care medicine at the Royal Cornwall Hospital, and he is the Deputy Clinical Director for the Southwest Critical Care Network. So Dave's been at the network for as long as I have, give or take a few months, and he recently won the Intensive Care Society Prize for the best talk at the Intensive Care Society meeting in Liverpool in June. He's going to talk to us about perioperative care. For those of you that don't know, Royal Cornwall Hospital has got a long and well-established enhanced perioperative care unit, who I'm sure Dave's going to talk about it, but their enhanced perioperative care unit is vital to the hospital putting through some of their high-risk cases. For those of you that don't have or would like to have an enhanced perioperative care unit, I'd strongly encourage you to touch base with the staff at Royal Cornwall Hospital, because the setup they've got there is superb. And whilst many of us are struggling for critical care beds, expanding your enhanced care capability may well liberate some intensive care beds. So it's something that you may all want to think about as you listen to Dave's talk. So Dave, are you happy to kick off? And thank you once again for stepping in with basically an hour's notice.
That's all right. Thanks, Andy. Let's share this. And then, oh, that's not right. Let's get up there. Where's PowerPoint? There we go. Okay, is that sharing okay?
Yeah.
Okay, great. Okay, so the title of this talk is Perioperative Risk and Enhanced Perioperative Care.
Actually, Dave, can I just ask
you
to, no, your slides are up, but there's just a question, so I'm worried that someone can't access it or something. Claire, have you got is something not working for you?
Sorry, I think I just accidentally put my hand up, sorry.
No worries.
That's all right. Let's see if we make this, because just now the slides didn't seem to be moving. Ah, there we go. Are they moving for everyone else? Because I know sometimes that can be an issue. Yeah, great. Yes. Okay. Yeah. So so the contents are going to be a review of the evidence base for enhanced perioperative care. We're going to run through some of the findings from the PEACH evaluation that we conducted in the Southwest, and then I thought to talk a little bit about the enhanced perioperative care unit we've got at Cornwall and the impact that's had and the relative benefits that we've had. Why won't my slides move? Ah, there we go. Okay, so which patients are at risk of post-operative problems? Well, there's the concept of the high-risk surgical population, and probably the first big study to identify this is Rupert Pearce's evaluation in 2006. So this looked at 96 UK hospitals using 2 data sets, and operations were grouped in terms of major procedure codes and then put into more general codes. And the overall mortality rates for each operation code was looked at, and any operation that had a post-operative mortality rate of greater than 5% at 30 days was put together. So this created a high-risk group based on operation code, and within that group, 83.8% of post-operative deaths occurred, but it was only 12.5% of procedures, with a very long medium length of stay. So what this suggests is that there is a population that have a much higher, a disproportionate risk of post-operative problems, and potentially by focusing on those patients, we could reduce post-operative deaths and complications. It's important to say that this is a study of surgical procedures. It's not individualised for patients, but the concept of the high-risk group still persists. There was a follow-on evaluation by Shamjanji at the Royal London, and this looked at post-operative critical care utilisation for the high-risk patients. So essentially used the same operation codes and looked at what happens to those patients post-operatively. By looking at that, 9.3% of the case, so it's a 3-year period, 9.3% of cases were considered high risk by operation code. And that group had a 12.2% mortality, and again, it accounted for a disproportionate amount of deaths. So 70% of deaths within this evaluation occurred within that high-risk group. And again, there's a really high length of stay for these patients, a median length of stay of 16 days versus 3 days. What was interesting is that only 35% of those patients went to critical care, and actually only 90% of those went directly, so 10% were after deterioration on the ward. Probably the next big evaluation to talk about was the NCPOD evaluation in 2011 called Knowing the Risk. So this is a 1-week prospective evaluation of all UK inpatient surgery. Here, it was more individualized. So high risk was defined by the anaesthetist opinion. So anaesthetists were asked, did you think this patient has a high perioperative risk of complications and death? And 20% of patients within this that were operated on within that week were considered to be high risk, of which half were elective. It's interesting to note that actually quite a lot of those high risk patients actually fell in the ASA 1 to 2 category, probably, you know, sort of underlining what a blunt tool ASA is for picking out high risk patients. Now, again, 75% of deaths occurred within the high risk population, and there was a 30-day mortality rate for this high risk group of 6.2%, compared to the other 80% of patients where the risk of death was only 0.4% overall. Of those high risk patients, only 22% went to critical care post-operatively. This is as ever with sort of these NC-POD reviews, there was a peer review component as well. One of the comments from the expert reviews of cases, there wasn't actually a consensus about what constitutes high risk, but it was interesting to note that care was considered only to be good in 48% of cases, so potentially lots of room for improvement. I wasn't going to go into the details for this NC-POD study, but again, it highlights the importance of sort of higher level post-operative care. Well, there's a little beep then, is that? I can't actually see everyone because of sharing the screen. So this concluded that in elderly patients, so these are patients older than 85, I think it's 80 or 85 years of age, that there was insufficient use of post-operative higher level care. At this point, I should mention the National Emergency Laparotomy Audit. So the Royal College of Surgeons published a higher risk surgical patient document, and that very much drew on the studies I've mentioned and the evaluations I've mentioned already. And this aimed to look at patients having emergency laparotomies, accepting that these patients had a very high risk post-operative risk that probably wasn't fully realised and managed. 50% of patients having emergency laparotomies within the year, this year that's presented, had a predicted mortality of over 5%. In fact, the overall mortality was 9.2%. So, you know, patients having emergency laparotomies have a high risk, and obviously we're all very familiar now with NELA, but until NELA came along, it wasn't a risk that was fully evaluated. Despite the recommendations, despite the time that NELA's been running for, 20% of patients within the 20 to 21 year were not admitted to critical care. So which patients are at risk? Well, I think we can conclude there's a high risk surgical population. That population is numerically is small-ish, but it has a disproportionately high mortality rate. And despite lots of work that's been done, a reasonable proportion of those patients are still not admitted to critical care or to enhanced care post-operatively. So the next part of this talk is to look at the impact of post-operative complications. And you can't really talk about that without mentioning Curry's paper from 2005. So this is a really big evaluation. So 105,000 patients over an 8-year period. So 8 major operations were looked at, and then a series of multiple logistic regression analyses were used to try and isolate pre, inter, and post-operative risk factors for death and for post-operative, for post-operative death. So this is the data for looking at the probability of survival in patients based upon whether there was no post-operative complications, whether they developed infective complications. What you can see is that patients that develop infective post-operative complications have a much higher probability of dying than those that don't. I mean, what's particularly interesting about this is that the risk of post-op, the relative risk of dying persists for up to 8 years after the initial complications happened. And I think it's got to be taken with a certain pinch of salt, because this is regression analysis and because it's only looking at specific risk factors. There's always the worry that there's unknown factors going on with patients. So, you know, there may have been underlying malignancy that wasn't known about, etc. So you are just picking out you're more likely to have a post-operative complication if they're present. So there isn't a sort of an associative factor here. But nonetheless, this really highlights just how significant post-operative complications are, and that patients that develop them are at much higher risk of death post-operatively. Oh, there we go. This is a separate evaluation by Farad. So this looked at patients who are really poorly. So this is patients with colorectal cancer and colorectal metastases having hepatic resections. What Farad looked to do was try and remove the patients that, so anyone that died within the first 30 days was excluded from this analysis. So it's looking at the long-term impact of post-operative complications within this very high-risk group. And there's really clear separation of the Kaplan-Meier curve here. You can see that patients that develop a post-operative infection are far more likely to die than those that don't. I'll briefly mention some information from the NCPOD study. Whilst it wasn't specifically designed to look at the impact of post-operative complications, it didn't stratify for the other risk factors that patients had. It still found that patients who develop a complication had a much higher 30-day mortality rate than those that don't. So 13.2% versus 5.7%. This study this is a Canadian investigation. It's single centre. But what it does show is the impact that post-operative complications have on the cost of care and the length of stay of patients. So when you start looking at the economic argument behind increasing post-operative care beds, this is a very powerful investigation. So a Canadian study, 2 years, 7,500 patients, and there was some stratification for pre-operative factors and surgical characteristics. What it found that 7% of patients developed a post-operative complication, but that group of patients, the total cost of care was almost twice as much, and the length of stay was more than twice as much. So economically, patients that have post-operative complications have a big impact upon hospital throughput and the ability to care for more patients. So what can we say about patients that develop post-operative complications? Well, there's a lot of associative and inferential evidence suggests that they have an increased short and possibly long-term mortality, and that post-operative complications roughly double the length of stay and the cost of care for patients, for hospitals. So I think the next question from that, having identified a higher risk group and having looked at the impact of post-operative complications, is post-operative admission to critical care beneficial? And this is a really hard question to answer, and there isn't, there's no golden randomized control trial out there to show, but there is a lot of evidence to support the idea that post-operative care is beneficial. So this is an investigation within the UK by Simmons. It's a 9-year retrospective review, and it found that hospitals that have a low provision of critical care beds have a higher post-operative mortality rate. I mean, from the very outset, you can see how there are other reasons to explain this. Presumably hospitals that have less post-operative care beds may have access to less other resources as well. But still, it's a powerful signal, I think. So what the study did, it looked at mortality rates for patients within each hospital, and then looked at the number of critical care beds, and then tried to split the whole data set into those that had the higher risk of death and those that had a lower risk, grouped them together, and found that there's a very strong association for the organisations with a higher risk of death with having a lower number of critical care beds. And you can see the sort of the analysis there, that critical care bed provision was 14 versus 20.8 per 100 beds. For organisations that had lower versus higher mortality rates. This is a further evaluation. This is by Gillies in Scotland, and it looked at the regional variation of critical care provision and outcomes after high-risk surgery. So it used the UK or the English ICNARC and Scottish SIGSAG data sets. So there's an awful lot of patient records. So 16,000 patient records were looked at over 207 ICUs. And what you can see from the graph on the right, there's quite a wide variation in mortality rate between hospitals, but not a strong association with the number of admissions that go into hospitals. what the investigators did next was perform an increasingly complex series of regression analyses, and the statistics gets really complicated. Most of it's actually in supplementary data within the study. But after a series of regression analyses, the authors found the strongest association wasn't necessarily the number of hospital beds that were available, but the utilization of those beds. So if you stratify organisations for the number of surgical admissions per operations performed, then the variation within the data set essentially gets lost. So the strongest association is beds per operations performed, a sense, and that was termed to be critical care bed utilisation. So this is the SNAP2 data set. So again, this is a 7-day cohort study within the UK, and it looked at the availability of critical care beds. And there was a strong association that hospitals that had less bed availability had a much higher rate of cancelling operations, and this sort of feeds into some of the studies earlier looking at the costs of and follow-on costs of post-operative complications. Has there been any randomized studies of enhanced care? Well, there is one that's performed in Denmark. I think one of the challenges of this is what was defined as enhanced care in Denmark isn't necessarily the same as what we would consider enhanced care to be in the UK. So there wasn't a requirement for arterial line access, for example. Patients within their enhanced care, they were allowed to receive one organ support. So you could be on some metaraminol, you could have some NIV, but that was it, essentially. But nonetheless, it's a randomized study. So looking at patients that had emergency abdominal surgery, patients had an Apache 2 score of greater than 10, and then patients were randomized to either receive 48 hours of intermediate care, as they termed it, or to go to ward care. They only managed to recruit 286 patients, and unfortunately there was no treatment. There was slow recruitment, is the first thing to say, and there's no significant difference between the two study arms that actually got stopped early. But yeah, someone has attempted to do a randomized study of enhanced care. So I think one of the things you say, well, what happens in enhanced post-operative care units and critical care units that might be beneficial? Well, one of the things that could be done is an improved delivery of enhanced recovery. So this is the results of the enhanced recovery surgery program in the UK. It's called the Enhanced Recovery Partnership Program. So it's 4 years of the program was analysed. So that's almost 25,000 patients. And what this evaluation found, that the compliance of enhanced recovery programs did have an association with reduced median length of stay for colorectal, orthopedic, and gynecological surgery. So the way this is done is that if units had a compliance rate of 80%, well, there was a split. So a compliance rate of the enhanced recovery program above 80% versus below 80%, and that found that median length of stay was reduced for between 1 and 3 days, depending on the operation type. And then with a bit more analysis, an estimated cost saving of £100 to £2,300. Here's a sort of a second evaluation, look at a similar thing. So this is the POWER study. I believe the POWER study was initially done to look at the effects of obesity on post-operative problems, but this is a subgroup analysis, and it found that compliance with enhanced recovery led to a lower association with complications. So it supports the UK data set, and this is actually a randomised evaluation. There is one study that suggests post-operative care might increase mortality, but this wasn't. No, sorry, this is the study that looked at obesity and post-operative complications, and so this is the subgroup analysis. Apologies, I got the two the wrong way around. The problem with this is that there was no randomization. It was all retrospective. So you're looking at patients that come to critical care or don't. Well, obviously, sicker patients that are going to come to critical care, and most of the authors did try to exclude some of their own risk factors. I'm not sure a non-randomized study of patients going to critical care really shows very much, but it's worth putting in there because it's part of the literature. So is post-operative critical care admission beneficial? Well, there's a series of studies suggesting that it's associated with post-operative survival and less complications. There's an evaluation in the UK showing that bed availability is strongly associated with the cancellation of operations. And there's also data showing that if we can deliver enhanced recovery programs, it's again associated with reduced length of stay. So I don't think we're ever going to find a perfect sort of randomized control studies showing that post-operative care is beneficial, but there's lots of signals within the data sets we've got to suggest it is. So we talked a little bit about the evidence base for high-risk surgical patients, what happens to patients if they develop post-operative complications, and also the relative benefits of critical care. So the next question is, what about how our capacity to admit patients post-operatively? Well, it's obviously quite widely recognised that UK critical care bed provision isn't very good compared to the rest of the developed world. An evaluation back in 2010 shows we've got 3.5 beds per 100,000 population. That's dramatically less than most of Europe and America. And on the back of that, I think it's worth mentioning Rupert Pearce's USOS study that showed a variation in mortality throughout Europe and the world. Throughout Europe.
Didn't really take longer than 2 minutes. I did put approx 2 minutes as well.
So the next question is how.
Yeah, but well, it wasn't a tip.
Oh, I think someone's got a microphone on.
Only the last one.
Last two,
Or it was the last one was any comments.
but the ones before it.
Great. Okay. So how best to use resources? So if we have a pot of money available to look after patients post-operatively, there's two sort of critical care based options really. You could have a higher admissions or routine admissions to post-operative care, or a really good track and trigger system to look at patients who deteriorate and then admit them. And I think the reality has to be somewhere between the two, doesn't it? Both strategies are important for looking after patients post-operatively. So in summary, UK critical care bed provision is significantly less than the rest of the developed world. So, putting all that data together, all those studies, there's been a series of publications and recommendations for the high-risk surgical patients. And these have been published by the Centre for Perioperative Care, by the Faculty for Intensive Care Medicine, by the Royal College of Surgeons, supported by guidance from NCPOD and NICE. And collectively, there is guidance that suggests patients with a moderate risk of death, so those with a mortality rate of 1 to 5%, should be considered for enhanced care. And those with predicted mortality of over 5%, termed high risk, should be considered for critical care. I'll just have a quick look in terms of Andy. How are we for time? Is it till 1:45?
You're good, Dave, because we started a bit early. So
we've got until 2, haven't we?
Yeah, we've got until about 2, just sort of just before that, and that'll leave plenty of time for questions.
And that still leaves time for questions. Okay, fine. So I thought I'd just we've already presented the PEACH evaluation in the Southwest, but I'll quickly run through the key findings from it, because it sort of builds very much on what we've talked about so far. So what we aim to look at with PEACH was the provision of critical care beds within sorry, let me say that again. We aim to look at where patients with moderate predicted post-operative risk and high risk went to post-operatively. Let me just go through. So we conducted a 1-week prospective observational study. We looked at all 19 acute trusts within the Southwest Critical Care Network, and there were 2 arms to this study. We looked at patients, we tried to capture all operations that happened that required an overnight stay under the care of an anaesthetist, and we also looked at referrals to critical care. Probably, in the interest of time, well, let me go through quickly. It's probably easier. So I pretty much said all this, haven't I? So we looked at every procedure with an overnight stay. So what we did, within each operating theatre, there was a QR code, and we asked the anaesthetist looking after patients to scan the code for each operation that happened and then record the relevant data. And that enabled us to calculate a SORT score. So SORT's a recognised post-operative risk scoring system that incorporates ASA, operation type, age, etc., and gives a predicted 30-day mortality for patients. We then asked the anaesthetist to record where the patient went. And just so we excluded day case obstetrics, paediatrics and cardiac surgery because they all have different pathways. So this is the SORT score, and includes some sort of readily available information to predict post-operative mortality. So we managed to capture 1,728 patients, and for a freedom of information request, we found out that represented about a 78% capture rate. So that's a lot of operations that happened in the Southwest captured. So we were very happy with that rate. What we found is that approximately 40% of operations happening in the Southwest would be considered either medium or high risk. So the medium risk group was 24% and the high risk group was 14.5%. I think that's slightly higher than I expected it to be before we conducted the evaluation. So what happened to those patients? Well, unfortunately, the majority of moderate and high risk patients actually went to the ward. You can see here that the blue bar represents ward admissions. So the over 80% of moderate risk patients went to the ward with recommendations for them to go to enhanced care, and almost 70% of high risk patients went to the ward with recommendations to consider critical care. We then tried to look at the data set a little, or we record some additional information because we were interested in whether, I'll take that away for a second, if the team, because the SORT scores we're talking about, the team was actually blinded to, we calculated. So the next part we're interested in was if the team caring for the patient had or knew the patient was higher risk, would that lead to any changes? Because quite a lot of patients coming into operations would have had a risk score calculated through their preoperative assessment. So this is looking at patients where the team caring for the patient actually knew a perioperative risk score. And there is an improvement. There are more patients going to enhanced care and to critical care, both in the moderate and high risk groups. But still, even if there's a patient is known to be high risk, known to be moderate risk, still the majority are going to ward level care. And within the high risk group, there is still, approximately half the patients are still going to the ward. The final question we asked anaesthetists caring for the patient was if there was anything specific about that patient that made them think the patient should go to enhanced care or critical care afterwards. This led to an improvement. So in 58% of cases where the anaesthetist felt enhanced or critical care would be beneficial, the patient went to enhanced or critical care. But still, that's 40% of patients where an anaesthetist felt an enhanced or critical care bed would be beneficial. The patient did not go. We looked at the numbers for patients who by national guidance, based on risk score, should have gone to post-operative to an enhanced or critical care bed, and then tried to work out how many extra beds we would need to meet the shortfall in the Southwest. What we found is that we probably need an additional 75 enhanced or critical care beds in the Southwest. And that would take our the number of beds within the Southwest from 6.73 to 8.4 beds per 100,000. I think one thing I did sort of skip through and so I had to speed up the talk was to mention that the Southwest has less critical care beds than the majority of regions in the UK. So the national average in the UK is 8.43 beds per 100,000. We have 6.73, but if we were to go up to the national average, we will be able to care for all of our moderate and high risk surgical patients as per national guidance. I will skip past that. And this is just a quick slide looking at the distribution of between different operation types. You can see the majority of patients going who are moderate or high risk are orthopedic patients. But actually, depending on operation type, some surgical specialities have a higher proportion of high risk patients. And you can see how the vascular surgical group, whilst being smaller in number, has a high proportion of high risk patients. This is the variation within the Southwest. It's anonymised, but you can see there is quite a variation between trusts within the Southwest of moderate and high risk patients. So that's that data. So the conclusions from the perioperative arm of the PEACH study was that 39% of surgical activity in the Southwest is medium or high risk, that only 20% of medium or high risk patients are admitted to enhanced or critical care, but that if there's a higher perception of risk within the caring team, there is a higher likelihood of patients being admitted to enhanced or critical care. But still, even where patients were thought to benefit from critical care, only 58% went. The second part of the PEACH evaluation was to try and look at the impact of emergency referrals and bed capacity. So for this part of the evaluation, critical care consultants in every hospital were surveyed twice daily by our trainee research groups. And they're asked to record all referrals, the consultant's opinion about the requirement for that referral being admitted, and actually what happened to that patient. There was an excellent capture rate, essentially 100%, and that's down to the hard work of our trainee groups. Within this time period, within the 1 week evaluation period, there was a mean number of beds available for each unit within the Southwest was 2.16. So that's 2 beds, and got to be a little bit careful with that statistic because obviously there's quite a variation in size of critical care unit. So perhaps a more useful way of looking at it is that on 14% of occasions, a unit had no bed to admit to. On 37% of occasions, there was only 1 bed to admit to, and on 70% there was only 2. So this has got quite a big impact on the decision to admit a higher risk surgical patient. If there's only 1 bed left, you're probably not going to admit an elective patient to that bed because it needs to be reserved and kept open in case of an emergency arriving. There were 5 operations cancelled during the 1 week period of the study evaluation because there was no critical care bed available. So how many referrals happened? Well, in total, there were 680 patients referred to critical care during the 1 week evaluation, of which about 40% were admitted and about 60% were declined. So we thought we'd look at the decision to admit in slightly more detail. In addition, so there were on almost 80% of occasions, there were more patients referred than there were available beds. So why were patients declined admission? Well, there were a range of options given. In the majority of occasions, the reason a patient wasn't admitted to critical care was because the admitting or the consultant in charge of the unit felt the patient was too well. In only 3.5%, it was felt that the patient would benefit, but there wasn't capacity to admit. I think we then tried to look at teasing apart this concept of a patient being too well. If on 37% of occasions there was only 1 bed available, and yet 60% of times, 60% of referrals were declined, were those patients really too well? And I think what it suggests, and when you take into account the limited bed availability within the UK or bed provision, I should say, in the UK and within the Southwest, perhaps there is a learned threshold that's become too high for admitting patients. And if we had more beds, we perhaps wouldn't consider those patients too well. And rather than admitting patients for organ support when they've deteriorated, we'd be able to admit patients preemptively to stop them getting poorly. So we propose from this data set that there's a learned high threshold for critical care admission, and that's because of a limited bed availability. So the conclusions from the PEACH evaluation, within the surgical arm, we captured 1,730 patients. That's a very high capture rate. Within the Southwest, about 40% of surgical activity is moderate to high risk, but only 20% of patients are admitted to critical care or enhanced care. And the critical care admission information that we captured would suggest there's a learned high threshold for admission to critical care. And there's an awful lot of people involved in collecting the PEACH data. So there's a big thank you to everyone involved and to all our trainee groups. What I hope to do is quickly mention our enhanced perioperative care unit in Royal Cornwall, which we're really proud of. And you can't do that. So Rob and Ian run it, and these are their slides, and they deserve all the credit for the success of our EPOC. So EPOC was set up to improve patient experience and try and stop operations being cancelled. So it's essentially a ring-fenced area that started off as 4 beds and has moved on to 7 or 8 beds. A business case was put forward. It was a joint business case with Critical Care. It was approved in 2021. It opened in June 2021 with 4 beds and expanded to 7 beds in December 2022. What happens is that patients go through a sort of standardised pre-assessment, and if they're predicted to have a higher risk, they then get referred to an anaesthetic consultant to review. They then get listed for an EPOC bed, and beds and operations are sort of set up appropriately to try and manage flow through the unit. The medical cover is a consultant, anaesthetist or critical care consultant will do a ward round every morning. The surgical teams will also review the patients every morning. And the nursing cover, there's a dedicated clinical fellow there, and the nursing cover is essentially a HDU level nursing cover, so 1 nurse to 2 patients. It runs from Monday to Saturday, so occasionally patients that are there on Saturday that still aren't ready for the ward are brought over to the adult critical care unit. And this is just sort of an overall look at numbers coming through, but what I thought I'd do in the interest of time is quickly go through and see. So this is our elective booking for higher level care. So you can see when EPOC started off in April 2021, and you can see the HDU bookings to the adult unit. Where's my mouse gone? And as soon as EPOC started, our booking to the HDU decreased significantly. So the first thing we can say is that we've essentially freed up HDU capacity by having an EPOC. And you can see the number, actually, if you sort of add these two together, the total number of patients being cared for in a high level care environment has dramatically increased. That's the first thing to say. If we then look at the sort of ASA scores for patients who are being cared for, we can see that just let me get this data set right. Well, it's a split, but it just shows the relative ASA scores being admitted to enhanced EPOC. Some of the median length of stay data for the hospital is quite interesting. So there's a suggestion, and this is looking at specific operations, that patients that are cared for on EPOC actually have an overall reduced length of stay in the hospital. I think, so this is our right hemicolectomy outcomes, and there was initially a reduction overall length of stay for the patient admitted to EPOC compared to the ward. And this has got to bear in mind that the patients coming to EPOC are higher risk. This is the anterior section data. And again, with the eye of faith, there is a reduced overall length of stay in the hospital for patients that are admitted to EPOC. And possibly for carotid endarterectomy as well. Right. How am I doing for time? Probably need to stop seeing name today. So this is, I'll really quickly describe it. So what have we found since we put the EPOC in place? We've had less cancellations since EPOC has started. We've had improved flow through theatres. We've had a reduction in patients staying in recovery overnight. Well, essentially, we don't have patients staying in recovery overnight. In the past, that used to be sort of our temporary EPOC where patients would go when they weren't quite ready for the ward and we couldn't bring them to critical care. And EPOC's had a massive impact on that. So that's far less likely to happen. There are less admissions coming through to critical care as an emergency since EPOC's been put in place. Overall length of stays for these patients have been reduced. And we've also freed up critical care beds for emergency patients by having the EPOC in place. I'm going to stop there because it's quite a lot to go through and invite questions. And sorry if some of it was a little bit, took a bit of time to get through, but I had to just familiarise myself with it. Thank you.
Dave, thank you. Thank you very much. That was really interesting. I think we all just need to bear in mind that Dave put that together with less than an hour's notice after poor Nitin had to pull out. That was really fascinating. I think we're all struggling with the challenge of getting the right patients into higher care areas. And we're all struggling with a lack of enhanced and critical care beds in the southwest. So I think that was a great overview, a great summary of the literature, and it's really interesting to see exactly what goes on in Cornwall. So thank you for that. Dave, are you able to stop sharing, and I'll just see if there's any? I think you're just sharing your Teams meeting there. I'll open the floor for questions then. So we've got sort of 15 minutes for discussion and questions. Feel free to put your hand up or write a question in the chat. Okay, I'm going to start with a question. So my question is basically, how long should we be keeping these patients either in critical care, or how long do you tend to keep them in your enhanced care unit? So I work in Bath. If we admit a booked elective to intensive care and they get admitted at 7:30 at night, in the morning their noradrenaline is off and we're looking for a ward bed. But I know that their complications don't really happen. Well, some acute complications happen in those first sort of 12 hours, but the really significant complications happen in the sort of days up to sort of 5 days post-operatively. So how long is there anything in the evidence that suggests how long we should keep these patients for? And if not, how long do you tend to keep them for in your EPOC?
So I think the first thing is I'm not aware of any evidence in terms of time. It's the first thing to say. I think you're right. So post-operative complications most often happen on day 3, and patients have left by then. I think that's why a sort of a dual strategy, isn't it? And we talked a little bit about a good track and trigger system, so you can pick up on deteriorating patients. I guess one question is, even if you're not keeping patients for that full 3 days, does optimal care in the first 24 hours reduce the likelihood of problems? And you could sort of draw on goal-directed therapy evidence bases a little bit, I think. And I guess one of the conclusions from the meta-analysis of that is that there is probably reduced infections in patients that have some cardiovascular optimization, and just little things being right, such as making sure Clexane is prescribed, making sure antibiotics are prescribed, patients get set out in the morning. All those things are going to be beneficial. But I don't think you can give any hard evidence that that's the case. Routinely, we admit people for 24 hours. But obviously, if there's a actual organ support requirement, they'll stay longer. But actually, quite a lot of the patients that stay longer, it's the fact there's a consultant ward round in the morning and the patient's not ready to be at ward level care yet, and they'll stay for that length of time. If patients stay for more than 3 days, they get brought over to the adult critical care unit.
Okay, that's really helpful. Thanks. Peacher from Plymouth.
Yeah, hello. Thank you, David. That was very interesting. Can you tell me, I noticed that you said it's not an HDU, and yet it sounds as though it's a little bit like an HDU. And do you have, correct me if I'm wrong, do you have dedicated staff, or do they rotate through the ICU, or rotate through the nursing staff for the skills that you would require?
So it was set up initially. So the nurses that were sort of our senior nursing team came from the ICU, is the first thing to say. In terms of it not being a HG, well, so it is kitted out and ready to function. So if we ever needed surge, then it would function as a full ITU, and that's sort of our plan. God forbid COVID happens again, but that would be where we go. And it's got pendants, etc. In terms of the nursing training, it's some of our nurses have moved from the critical care unit there. The majority have moved from surgical wards in the hospital, or been employed as part of our international nurses program. And it's been a really good place, I think, and this is feedback and advice from my nursing colleagues, that it's been a great place to start training. and some of those nurses then want to move on to the adult critical care units as well. So the short answer is they're actually dedicated EPOC staff that come from a variety of places, and it's considered to be a really good training environment because it's obviously slightly less acuity than the adult unit.
Great. Thanks for that question, Peter. Thanks, Dave. Tim Cobby from North Devon. Hi, Tim.
Hi, I was just wondering about why we don't take them to ICU or enhanced care. And do you think it's because we haven't really got enough hard data saying the outcome is better, and we just need a bit more data saying they come here, they're going to have a short length stay, going to have better outcomes, and then we can persuade all our colleagues that they all need to come?
I'm not sure where any more data will come from, if I'm honest, Tim. I think you're never going to have sufficient equipoise, I don't think, for a full-blown randomized controlled trial of enhanced or critical care showing an improvement in outcome. And when we don't have that data for any patients that come to critical care, let alone sort of surgical patients post-operatively, I think there's enough. So you're then looking at, well, how can we tease that signal out? I think the reason for pulling out those aspects I did in the presentation at the start is that if we can identify a high risk group, if we can show that post-operative complications are almost certainly very bad for you, and if we can show that there are signals that critical care utilization, admission is associated with doing better, I think that's the best you're going to get. I'm not sure there's another way of conducting that, those evaluations. And then it's a case of saying, well, and I mean, that's been enough for multiple national bodies to release guidance, which is very clear. And then we've got an evaluation within a critical care network with a low bed provision showing that we can't, well, only 20% of patients who should be admitted as per that guidance are being admitted. I'm not sure, and we talked about it when Peter was completed, you know, where should we take this any further? And I'm not sure we can. I think that's the answer, isn't it? The bottom line is we need more beds, because it's the right thing to do. That's certainly my opinion, and I'm pretty sure Andy will probably say the same thing. I don't know. I'd be interested. How would you to put the question back, what would you propose? How would you propose we look at it?
Sorry, trying to find my speaker. It is very difficult, isn't it? I mean, we try and admit all our emergency laparotomies. How long you keep them for is very difficult. And it's just trying to work out whether you can get enough audit data, probably, isn't it, as you're doing, to demonstrate that actually their outcomes are better with short length of stays and less complications. But it's just trying to get the data into the other group of people, isn't it? So into the general anaesthetists and into the surgeons to say this is where they need to come.
I think so, and I think
we have the capacity, don't we? Which we don't necessarily always have. I think one of the things we do here is we actually, you know, if someone's been identified as needed to come, is that if we don't have capacity, is that they don't get done, rather than trying to fudge it. So we then trying to make actually, you know, it is a real thing that they need to be with us.
I mean, the Royal College of Surgeons suggests it should go on a patient's consent form, that if they are recommended to have enhanced or critical care and it's not available, it should be down as a risk on the consent form. And I know that's something we don't routinely do, but it was recommended. I think that, you know, that in terms of getting more beds, you play on the economic analysis probably more, and that's something we try to do. You know, the data is very clear that you stay twice as long, your costs of care are twice as long of a complication, and that's even ignoring the patients that you then can't operate on and the loss of funding from there. So there's a very powerful economic argument for it. And then, as you say, length of stay data, and collectively, I think our EPOC data shows improved length of stays, although I necessarily didn't maybe present it in the clearest way. Yeah.
Thanks, Tim. Thanks, Dave. So, Dave, there's a question from Vicky in the chat there. Hi, Vicky. If day 3 is the most likely for deterioration, has anyone created an EPOC discharge checklist to cover this? So on day 3, they get fluid review, formal bloods, etc., to quickly identify patients at risk of discharge, I suppose.
I'm not aware of that. I mean, I think the day 3 comes from preoperative studies. I think what we do have is, new scoring systems. But I suppose, yeah, should our outreach teams be routinely reviewing everyone on day 3? I don't know. There's probably not capacity to do that, is there? I think the key is when post-operative care is a standardized thing. Patients should follow a pathway. And when patients are no longer following that pathway, if the urinary catheter is still in, if they're still on oxygen, what's going on? Because they shouldn't be there at day 3 for most operations, should they? So I think you could probably quite easily create something built around an interventional checklist and whether they're ticking those boxes without even needing to do blood results. I think, if they're not mobilizing, they're still on oxygen, what's going on?
I suspect the majority of hospitals across the southwest have or are going to some form of electronic patient record, and it wouldn't be beyond the wit of man to pick out those moderate or high risk patients who don't come to enhanced or critical care and flag them for review by an outreach team. I mean, that would be possible given the electronic data processes that most hospitals have. I don't know that anyone's done that, but that would be quite a good mitigator for the lack of enhanced and critical care beds.
Yeah. Yeah, a bespoke track and trigger system is a really good idea, isn't it?
Any other thoughts or comments or questions for Dave? Brilliant. Okay, thanks, Dave. That was really interesting. Really good to see what happens across the southwest. Really good to see what happens in Cornwall. And thanks again for stepping in at less than an hour's notice.
Okay.
Okay, we're going to move on to our next speakers now. So Rory Cassidy is from University Hospitals in Plymouth, and Elaine Morley works in Cornwall, but also has a role with us at the network, and she's the sort of network link person for the Nurse Associate Programme. So if I can hand over to the two of you, they are going to talk to us about making the most of the GAP and network projects. So Rory and Elaine, over to you.
Shall I start as a sort of intro? I'll just present my screen. I'm from University of Plymouth, not University of Plymouth Hospitals. Not to correct everyone, I am in an academic role at the moment. Let me just share my screen.
Apologies.
That's all right. I'll give a potted history. I don't want. Oh God, now I'm going to have to be clinically credible. After the speaker before was the winner of the ICS presentation prize. No pressure then. Let me just share my screen. Yeah, so firstly, hello, thanks for letting me speak. I was surprised to be asked by Graham. Really, Elaine and I presented to a conference here in Plymouth a little while ago about the nurse and associate role. This is just, if I do a quick introduction as to my experiences with the role, because I think there's a case of sort of convergent evolution, and how I approached it within my clinical roles in the past. I'm not a career academic. I'm overwhelmingly clinical by background. That always reminds me of there's an interesting equation by Dienz and Miller who wrote about how to catch a cricket ball, and there's a huge equation with all the variables, but I'm pretty sure Tuffers didn't do the maths. He just sort of kept his eye on the ball and moved accordingly. And I don't want this to come across as academic speak is what I'm saying, because I don't want to be the tail trying to wag the dog. But essentially, I had some experience with the nurse and associate program with the clinical role, and I had a bit of background with the role as well. And I'm conscious that there is a network project. So just to give it a little bit of context, really, as I say, my background is in ICU or cardiothoracic ICU, having senior roles here in the southwest and in the northwest, as well as working in Sheffield and along the south coast in the past. Let me just go on to the next slide. And why I was surprised to be asked to present at the Nurse and Associate Conference here in Plymouth was because I was a little bit, not irritated, that's the bad word, but there are certain sort of organisational development, mission statements and things like bridging the gap was the one that really made me want to speak, because it's all about perception. We know that the nurse and associate role came from that report by Willis, and that shaped the shape of caring review and raising the bar. But in terms of the gap, where we don't see things honestly as they are, we quite often see them as we are. So where I could perceive a gap in practice, something like, oh, sorry, someone talking. Safe care or something similar. Might see as a gap in numbers of staff, and really in terms of my role as a manager and things in the past, I'm not particularly great at number crunching or being told what the problem is. I did try and have a look to see who was in from Bournemouth who might remember me from 25, 30 years ago, where I'm not particularly good at being told where my issues are. I'd much rather recognise them. But really the issues in practice about where the gap is, it's not just about numbers. We've got things like cohesion and ownership of tasks, and senior nurses not being able to step away time related to do those senior nurse responsibilities. And my problem was with who decides where that gap is, and how do you go about owning it. So I guess to give a bit of context about what shaped my view, because my view of the gap is going to be shaped by my experience, I can't be objective, is that I do have a clinical background. Without going into too much detail, I did go into advanced practice and matron roles in different areas. There's also working in Sheffield and Manchester in the noughties, had some experience of trialing new nursing roles, the trainee assistant practitioner and the assistant practitioner program, which at the time I can use that experience to recognise that it was poorly defined, and there was quite a lot of resistance to the roles, and perhaps because of the definition, rightly so. I was also part of the original University of Plymouth curriculum development team, which is the photo there, which makes me look like I'm standing on a box, or large and lurch-like, or that my peers are just quite short. But I perhaps had a better insight into the platforms and professional responsibilities that sat within that professional role, and also recognising that developing criticality and some stuff that I did on cohesion and organisational development, and some published work on that, and going back to an IC matron role, and all the issues with retention and staff burnout and things post-pandemic, and trying to retain staff who'd been through quite a traumatic experience. But most of all, overarchingly, is that we talk about coaching and role modelling, and actually I've been exposed to large units and smaller units in busy settings, and there's lots of opportunities there as long as I'm willing to sort of own it and advocate for it. And with regards to staffing and the nurse and associate role, that's the view that I took. They're not information heavy slides, but I addressed it as I would address quality improvement project. Look at what the drivers of what meeting those ICS guidelines, where are my staff? Where are the gaps within that? Do I have an appropriately skilled senior workforce that want to stay? How can I free up a little bit of time to let them do the role that they're equipped to do? I always think of Price's Law when I'm looking at staff, and it's an academic law citation. It says 50% of my literature review would be found by 10% of the authors. And I always wondered whether I could move that across to clinical practice. I know they've done it with banks back with the financial collapse, but I would always think, if you're asked to do an extra shift, you go to the off duty, but you don't necessarily count who's on. You look to see who's on with you. It suggests that perhaps I need to recognise and support those experienced and reliable staff, and give them time to share that knowledge, disseminate that knowledge. Anyway, what do I know, or what issues to address? Sorry, I'm conscious that Ruth's in the room. I don't have a pathological need to be right all the time. I put that photo in as an example because I always believed therapy dogs treated nurses but having seen it firsthand, I stand corrected. And the same would apply with anything that I'm talking about here. I'm quite happy to be wrong. So 1 in 2 adult critical care nurses were reported to be expecting to leave their roles over the next 3 years. And that's not from me, that's from the CC3N workforce survey, that overview report they did back in 2020. And we've still got those minimum requirements to meet in terms of staffing and levels of training, like the 50% during the ICU course to meet the GPICS recommended guidelines. Recruiting to establishment. So we quite often recruit as the fix, which would go against Price's Law for a start, but also I have to recognise early career nurses' turnover rates are amongst the highest in the workforce. Again, if you wanted to read around that, Holmes, and that was 2022, they talked about the floodgates being opened, and there was some work to do there. There's some interesting work coming out now about transition between undergraduate nurse training and into registration. When looking at trainee nurse and associates, how many of them wish to remain as a nurse and associate? And a significant proportion of those actually want to progress on to registered nurse status. Dainty, 2021, Kessler is another one that's published around here. How do you identify and sort of isolate a nurse and associate role while also developing those that want to go on and progress, which I think in Kessler it worked out about 8 in 10 nurse and associates. And if I was doing my training now, to be fair, not to incur too much of a cost, that's probably the way that I would approach it. On top of that, we're told 60% of chief nurses in England found it challenging to fit the nurse and associate role within established nursing teams. And actually, that Vanson and Beckett did the work around that. But actually, we probably, those on the shop floor, on the units, probably have a better insight into establishing that role than the chief nurses. But there is also a notion of nurse associates posing a threat to registered nurses, and consequently there's an overlap in roles. Yeardsley and Nash, that was based around community settings. But I think more generally, there is that perception, and I think I'm conscious, having Twitter, or X as it's known now, there are other healthcare related roles that cause conflict and resistance, and owning it was my main driver. Conscious of time, so I'll rattle through it, but essentially I saw this as an opportunity to grow my own stuff. If I am sensible in recruitment, I can look at examples of previous work, academic work. I can perhaps look at whether they'd be able to go on and study at degree level. And with a view that I could potentially have newly qualified nurses who at the point of registration have 4 years, 3 or 4 years critical care experience that I've supported through. And I also bypassed that issue with newly qualified nurses having very high turnover rates. Make it specific, like again, any QI project, we did look at something that was both realistic and achievable, but keeping SMART goals was sort of important. My actions, I'll try and rattle through. We did appoint 2 nursing associates recruit to post initially. One of them was in that photo, I think, is just qualified. And to find that role within the MGT, there is resistance. I can't say or claim that everything is perfect. There are always, if I look at Rogers' innovation curve and those that take, there's always early innovators or early adopters, but there's also always laggards that are a bit slow on, to accept and own innovation. Also made sure that it was part of a national working group for inclusion and exclusion criteria, so we could define the role to free up, away from criticality. So there was there wasn't as much overlap. It was more defined. Again, not problem-free, but took an active role in trying to set that framework. But I think that's currently being reviewed. There's also a national competency framework that could have guided that. I also would support applications for apprentice routes to go on and do their RN training. And then this project that Elaine's going to talk about came about, and we put the business case to the network to get some funding for trainee nursing associates. I think we've got 5 across the 2 sites within the trust, and also accessed some level 6 partnership modules to continue their academic development, because the clinical side of teaching comes clinically. The university, I'm in a university role at the minute. My job really is to teach people how to write. So getting on that pathway early, so they're better equipped to get through the degree RN training, and look to improve staffing numbers that way. There was a peer review from the network leads. I think it's testament actually to the team that was in place rather than anything else, but we did manage to increase over a short space of time the compliance with GPICS, cohesive. It was a cohesive, it still is a cohesive and highly motivated critical care team anyway. But the quality metrics were exceptional across the spectrum, and the organisation had made headway with recruitment and retention of critical care staff. What I'd actually done is put together a business case to change the staffing model so we could recognise this role in compliance with the GPICS or getting the post-registration qualification equating to a band 6. And that was the business case I put in. The top version's my really clumsy business case with all the GDPR stuff cut out, but it's essentially very like for like to the UK Critical Care Nursing Alliance workforce planning document that's just come out that I'm sure everyone's aware. And really, it was just to signpost there's a chance to make that pathway our own. I'm conscious that I'm not in a matron post anymore, but I am trying to get approved some postgraduate qualifications in critical care for nursing staff that I think should be led by clinical teachers and clinical staff rather than university. But I don't want to sound like a sales pitch. And really, hopefully, that gives a bit of context and I haven't waffled too much. And I'll hand over to Elaine and have some questions at the end. Is that okay?
Thanks, Rory. I'm just going to share my screen. Okay. So, as Rory said, is that there's a gap, and we've looked at evaluating the project so far, and looking at, is there anything in that gap that that we have missed? So if we look at the demographic profile within the Southwest for nursing associates, so this is not just in critical care, this is for all of the Southwest in acute hospitals. So we can see that, you know, we're looking at, you know, a female dominated profession that's young, between the ages of 20 and 24. And those are the individuals that the project is looking at trying to harness, because those are the individuals that may well be in supportive roles or assistive roles, that we can start that trajectory of their professional process. So some of the things that we've evaluated with this project is that we have to sometimes look at the myths. And it's always best to start with the elements of what a nursing associate cannot do, because if we know what they cannot do, then we can, you know, harness the skills that they can do and look at our policies within that. The skills that they cannot do, will never be able to prescribe drugs, they'll never be able to administer patient group directives, they'll never be able to section a patient, and they'll never be able to certify death. But if we look at the shared platforms that they are regulated by, is that they're still accountable, they're all about improving quality and safety, and they're all about providing and monitoring care and contributing to that care as well. So when we started this project 18 months ago, I started out by thinking, yeah, we've got huddles, we've got information, but now 18 months on, we've got some feedback from those student nursing associates and some of the nursing associates as well. So like Rory said, is that, you know, a lot of staff feel that, you know, is this just a substitute because we can't recruit nurses? But when we've asked lots of nursing associates, they've said, well, I don't consider myself a cheap nurse, and I respect that the registered nurses are taking on other tasks, and as they grow in their jobs, so will ours as well. And we can see that, you know, Rory said about, you know, are nursing associates a threat? Well, that's the opposite. They're an integral part of that professional team. Some of the questions we ask them is that, you know, when we look at any sort of clinical area, we've got talent out there and we're not really harnessing it. So as a nursing associate, they've still got limitations. They've got limitations on their role, but they've got good understanding of physical health, patient deterioration, medication, and enhancing their ability. But again, practice educators will say, you know, it's an untapped talent out there in that support worker profession. And how do we get them to think about developing their skills later on? We mentioned about, you know, does it add value to the team? And nursing associates and employers are starting to look at that scope of practice. So within the Southwest, the critical care units are looking at, you know, have we really got clarity around the role? Are we doing more for our nursing associates that make it easy to be part of that workforce? And definitely we can see that within the critical care units. But one of the feedback that we always get challenged about is intravenous drugs. And most of the matrons or any of the practice educators will say, look, you know, we've got nursing associates in critical care, but they're not allowed to give drugs because it's around our policies. So the first thing that I always suggest is that you review the policies and you challenge the wording. And the wording is usually around a nurse administrating a drug, but we've got allied health professionals out there, we've got ODPs, we've got physios that might actually be undertaking some of those skills. Looking at the education and training and ensuring that we're deploying the myths, and we're looking at if their understanding of those myths, and that will continue that process that they think that nursing associates cannot undertake that role. So we look at reviewing the incidents and are there any common themes for drug administration within critical care? And that is normally within qualified registered nurses. So is the training and assessment, is it robust enough? And could that be replicated for nursing associates? But it's like getting the word out for the peer groups, the vascular access teams, the medicines management teams, our chief pharmacists, and making the role as dynamic as it is, because as long as we or a trust understands what the perspectives are from the senior nurses, then that can start to be cascaded down. So some of the feedback that we've received over the past 15 months has all been around how do we change that skill. And some of the things that our staff have fed back is that look, staff in a critical care unit isn't all about the ratio of level 2 and level 3 nurses, patients, regarding, you know, RNs to that ratio. Our unit layout is different now, and if you think about unit layouts from 20 years ago, they are different now. They're not all in a, they might be in side rooms, they might be in 4-bedded bays or 2-bedded bays. But some of the staff wellbeing allocation, and we have to think about that, because a nurse who is in charge of a unit on a day-to-day basis is making dynamic decisions, and it may well be looking at, you know, should we be looking at the staffing establishment, the rostering template, looking at adverse events and the nursing workforce. So some of this feedback that we've been receiving over the past 15 months has been related to the doing part of how do we integrate nursing associates in critical care. As Rory said, the inclusion and exclusion criteria has defined the clarity of the role better. And this has brought about some questions about why have we changed it and why have we changed that inclusion and exclusion criteria. And the main reason is that historically we couldn't really see a difference between the nursing associate and the nurse. And sometimes the nursing associates would say, I'm doing everything that a nurse can do, but I'm being paid as a band 4. So we had to really challenge the competencies and look at those guidelines to say, yeah, what is that nursing associate undertaking? They're complementing the care, they're not replacing it. We can't suddenly find ourselves, you know, with a ratio that is reversed. So that's why we looked at, just a minute, the nursing associate can identify a career progression, because if she wants or he wants to undertake looking after a level 3, then that is a nurse's responsibility, different to a nursing associate. So the needs of the patient, we've from the feedback that we've been experiencing over the 15 months is that, you know, the needs of the patient should be directing the level of support, and the role that we've developed to bridge the gap from the healthcare assistant to a registered nurse all depends on the staffing template in any critical care unit. But the pilot has recognises that the registered nurse is there to lead and manage, and the nursing associate is there to prioritise, assess and implement that care. We know that the nursing associate is educated to the foundation degree, but they still have to revalidate and they're still regulated by the NMC. So that means that when we think about what this pilot has achieved, well, it really has championed the South West, because we now, from having nothing 15 months ago, we've now got 26 nursing associates within those 10 units around the South West, and we've got 21 student nursing associates that are now coming up to qualifying. It's now really embedded very well into the critical care units. We know that that role could be a stepping stone for that nursing associate into a registered nurse training, but that's all about growing our own staff, which is what Rory anticipated. But the value of the role is adaptability and how that can affect our healthcare profession. There are limitations, but with those limitations we have to think, how can we challenge those limitations, and should they be challenged as well? The one thing that we have found over the past 15 months is that, you know, we had limited time to implement this. We had to do an awful lot of communication, rollout, misunderstanding, and what we anticipated was we were almost changing things on the hoof, which caused a lot of challenging conversations with units. But what are the next steps? And that's the thing, is that, you know, what are the next steps in preparation to make this something that is normal for any critical care unit to look at? So what happens next? And this is the bit where, you know, the project completes in February 2025. We're going to be looking at, you know, has it had an impact on patient experience? Because that is the bit that we want to look at, which there's not much evidence around that, and not much research as well. It's relatively a new process. You know, we knew that nursing associates came out in 2019 after being implemented from 2017. So there's not that much research around it, but has it enabled some of the nurses to undertake more senior and advanced roles? You know, are the critical care units improving staff retention through career progression? And is it growing our own workforce? And can this be physically seen? Because we think we can see it, because we can, you know, we can look at how much and how many more nursing associates and student nursing associates we've got, but is that having a big impact on our units? And any questions? just stop sharing. Okay.
Thanks very much, Elaine. Thanks, Rory. That was really interesting to see all the hard work that's going on. There has been a lot of hard work gone on there. So thank you both very much. Questions, comments? Okay, so I'm going to get the ball rolling again. So obviously there was some stuff in the media over the last 6 months or so about patients not adequately understanding who was looking after them. And I think the comments in the media were particularly related to practitioners, where patients were thought they were being treated by doctors, and there was some discontent there. Do you think there needs to be anything like that in units which have nursing associates, so that patients and relatives can understand the suite of staff who may look after them?
Do you want me to answer, Rory? I think they should. I mean, this is one of the comments that was put out by the RCN, saying that it was a substitute. Staff, patients didn't understand what a nursing associate was. They didn't understand the differences between a nurse and a nursing associate. And the NMC has tried to protect that wording. We are a protected species when it comes to having that role of a nurse or the role of a nursing associate. But we didn't really promote it, and I think that's one of the things with staff, we haven't really promoted it. But you could also argue that the role of the ACCP, sometimes patients don't appreciate they're being managed by an ACCP as compared to an F1 or an F2, and because we've got so many diverse roles now, patients are confused. They don't know who they are, who they need to go to. I attended a conference last week, and there were primary care practitioners who would be there to assess patients for musculoskeletal disorders. And patients were saying, "So you're not a doctor then?" And the primary care practitioner said, "No, I'm an actual physio." And there's that difference, isn't it? Sometimes patients always want to have that. Am I being managed by a doctor? And what it's about us as professionals, isn't it? And identifying that patients do know who they're being managed by and assessed by. And I think that's the bit of the patient experience that I'd really like to look at. Rory, have you got anything to add?
Yeah, I don't want to get too involved in the PA discussions that are going on. Mainly, I program lead for intercalated medical, urgent emergency care and critical care degrees, and that's my, if I'm stuck for a debating topic to get everyone going, that's my fallback. But I think the difference with nursing staff is that it's not our first rodeo. There have been several new entrants in terms of, I mean, going as far, you could say there's a little bit of overlap with the old enrolled nurse role. These things have happened, so we're probably a little bit better at signposting that, because it's been part of our practice a little bit longer, to have that slight overlap in roles. Does that make sense?
Yeah, very much so. Yeah. Yeah,
I think as well, if it comes down to, sorry, in terms of what you're doing and IVs and being task orientated, well, if I go back and sit within an academic role, the only real difference between a foundation degree and an honours degree is the ability to think critically and make judgments based on a balanced and well-informed argument, as opposed to having evidence-based best practice, which is a foundation degree is less criticality. And I think where nursing's become a profession and has got a degree level qualification, we're less task orientated. We're becoming more critical in our practice, but so we don't see that encroachment of tasks in quite the same way. I would hope so anyway.
Yeah, thank you both. So other comments or questions? Dave.
Hi, Elaine. How you doing? It was a question about, because obviously initially when the nursing associates start, and where they would sort of see themselves and where they want to be. Does that change over the course of the program during interviews as they're sort of exposed to different roles in the department and things, or does that stay the same?
And you mean in terms of once they've qualified where they want to work?
Yeah, well, exactly. Well, we obviously one of your comments about it's not a sort of necessarily a bridge to full nursing, etc., and it's very much a role in its own right. But how many sort of say, well,
I see it very much as an access to become,
Yeah.
as a pathway to registered nurse. I don't think HEIs haven't been doing it long enough to have any worthwhile data for that to see where they go on point of qualification. I can look at other clinical areas, so areas like I know Birmingham have in their critical care units used, and a lot of their nurse associates have retained and stayed there post training on the unit. But I get that's anecdotal evidence rather than anything else.
And what we've found in the Southwest with our recruits that we've got, there's a 50-50 split. 50% are seeing it as a progression and 50 are valuing the role that they don't want to progress. And that's the bit that we wanted to try and look at, is that it's about valuing that role and not just seeing it as a progression onto their nurse training. It's about valuing that nursing associate in that critical care unit. And so we are seeing that 50-50 split, really.
50-50. Okay, thank you.
Thank you. Any other comments? Okay, great one. Thanks, guys. That was very interesting. Thank you for all your hard work. We started a bit ahead of time. It's not surprising, therefore, we finished this session a little bit ahead of time. So we've got a break now, and we're coming back at 3:15 for a rehab session from Nada and Jen from University Hospitals Dorset. And then after that, airway matters from Professor Tim Cook from the IUH in Bath. So break now. See you all back at 3:15, and we'll kick off promptly then. Thank you.
Andy, I'm going to step away if that's all right, unless you want me to stay for anything. I'd said all that previously, but I was on mute.
Thanks, Rory. Thanks for coming along. Appreciate your time. Oh, hi, Andy. As you just joined us, we're just on a break till 3:15. Cheers.
Great. I don't know if you can hear me, but thanks.
Yeah, no worries. Okay, guys, I think it's 1:15. I think we'll just give it another 20 seconds for everyone to come back and then we'll get going. It's always slightly nerve-wracking when everyone's camera's off when we're restarting because you never know if anyone's actually back or not. But let's just give it a moment and then we'll kick off. Nada and Jen, are you guys ready?
Yeah, here ready. It's just a matter if my presentation will load up quickly or not.
Okay, great. No worries. Thank you for coming.
Pleasure.
Is Jen joining you or is it just you, Nada?
I'm just in
Jen
a
is
different location.
Ah, perfect. Sorry, you weren't on my screen, Jen.
It's all good.
Right, I think we'll get going again. It's 16 minutes past. So welcome back, everyone. Hope you've managed to have a little break. So for those of you who've joined, this is the second part of today's Southwest Critical Care Clinical Forum. We've had a medical talk and nursing talk this morning, and this afternoon, the latter part of this afternoon, we've now got a rehab talk, and then we're going to finish the day off with another medical talk about airways. But first of all, I would like to welcome Jen and Nada from University Hospitals Dorset. So Dorset is slightly affiliated to the Southwest Critical Care Network in that it's outside of our footprint for clinical activity, but is in our footprint for NHS England commissioning activity. So there's a little bit of overlap. And one of the consultants in Dorset, Martin Schuster-Bruce, kind of is the sort of link person between the two networks who oversee Dorset. So Jen and Nada work at University Hospitals Dorset. So thank you very much for joining us. Physiotherapists, I understand. I'm going to hand over the reins to you guys, and thank you very much for joining us.
Thank you very much for that introduction. Hopefully everyone can hear me. I'm going to attempt to share my presentation. Bear with me. If I do this, hopefully you should be able to see something, hopefully.
Yeah, that's good.
Perfect. So thank you for the introduction. So this is I'm Nada Farhead, physiotherapist here at UHD. Well, I guess physiotherapist and now a trainee ACCP. But when this was when this audit or this piece of work that was done, I was a physiotherapist on critical care with Jen as my clinical lead. So this presentation is on behalf of the wider rehab after critical illness team here at RBH or UHD. So over here at Bournemouth, we were doing a therapy follow-up service essentially. So when patients were stepped down to the wards, we had therapy going out to the wards and giving them additional therapy sessions on top of what they've received normally on the normal beds. And we just thought, we asked a simple question, which was, is what we're doing the thing that we want it to do? Which is, it sounds silly, but it's sometimes a very important question to ask. It's the only way you find out if what you're implementing has the desired effect, and if it's not, you can implement some changes or see where it's at. So we start off with a very simple question. So from that, this piece of work was spawned. So the objectives of this presentation in particular is to give you an idea of the inclusion criteria of our patients that we looked at and we provided therapy for, to have a look at some of the methods of the data extraction, so you understand how we pulled this information out, which included length of stay, discharge outcomes, and costs, which a lot of people are interested in because it might be important depending where you're at. And also looked at future opportunities, any adjustments made, and considerations about further work or the work that we conducted. So rehab after critical illness here at Bournemouth Hospital in particular, when this piece of work was actually done, it was very well staffed, actually met the GPIC standards and provisions. Leadership afforded the extra post sort of just off the back end of COVID times to make this rehab possible, we have access to a therapy assistant and an occupational therapist
Okay.
within the bracket of rehab after critical illness.
Actually working from home on Friday. I'll swap my shift
The-
on Thursday to a 9 till 5. So then
Right, it's-
I'll try and find them and mute them.
Get over now, joking. The inclusion criteria we had, we looked at patients who were ventilated for more than 3 days, patients who were receiving level 2 care for more than 5 days on the unit. Anyone who had an emergency operation who came through at Bournemouth was included in follow-up, and any patients who had a CAM ICU positive score were also initially captured. Some of the data extraction. We decided to look at Paul Hospital against Bournemouth Hospital. So Paul has a follow-up service, no FLED. The difference between Bournemouth is there is no therapy services in terms of step down follow-up once the patient goes down to a ward. So all they have is just the normal therapy they receive. So we thought it would be a really good idea to compare the two hospitals together. So we did a like-for-like comparison essentially of Bournemouth patients and Paul patients. We extracted data using Medicus, EPR, and ICCA, which is sort of the notes platform for ITU, and using those parameters, those pieces of data, we can extract things like length of stay, how long was each session, the illness status, how long they ventilated, all those data points to try and match them up as close as possible. We picked a time period basically of the midpoint of from January 1st to the 30th of June, so 6 months across 2023. So the metrics of each patient. So in the middle column here, hopefully you can see my mouse. If not, I can maybe do laser pointer. We have Paul here and Bournemouth here next to it. So we had included almost a similar data set, 30 to 40 patients. Paul has a larger exclusion criteria simply because we had to cast a larger net and sift through who to remove out of comparison. So Paul's a trauma centre. Bournemouth doesn't receive those patients. Anyone ventilated for more than 3 days or had level 2 care who was trauma, we had to then exclude out. They have a lot of ENT patients who we don't have in Bournemouth, so it would have been an unfair comparison to join them up together. So that's why you're seeing a higher exclusion rate at Paul Hospital, basically. And then you can run through sort of the ventilated patients, the level 2 patients, the number of trachea patients, etc., etc. And there's a fairly even distribution. There's some differences in emergency op and the ventilated more than 3 days. The delirium patients here we tried to capture, we found it inconsistent, and we didn't feel confident that the reporting of patients who were either positive or negative CAM ICU. So we decided to exclude them completely because we just didn't feel we had a good handle on whether people were or weren't delirious. So we just removed them for ease and to actually dig down into the patients who were meeting the above criteria. And here we are just highlighting some of the things I went through. Yeah, ventilated, level 2, trachea, op, and delirium. Perfect. So what did our stats overall say? So here we have the overall patient length of stay. In the grey, you have Paul Hospital. In the orange, you're going to have the Bournemouth Hospital patients who received additional therapy. So here we have the total all overall patients, the ITU length of stay, the ward length of stay, and the hospital length of stay, mean averages. And if we put in Bournemouth here on top, we can see with the additional rehab, we had a slight reduction of median hospital length of stay for about 2 days. And a reduction of about almost 6 days mean length of stay. So from that data, we managed to pull out the discharge pathways for Paul patients and Bournemouth patients, and we found that overall the Bournemouth patients who had the rehab after critical illness therapy additional had a over 80% pathway 0. So pathway 0 is going home at baseline or home with community therapy. So not having reablement, no increased package of care, no package of care. Interim bids, care homes, so a significant increase in pathway 0 compared to Paul. And we repeated this for level 3 patients. So here we have Paul, and then next to him we have Bournemouth. So a median reduction of 1 day overall hospital length of stay, and a difference in mean. And here we have our pathways, so just under 50% for Paul, and over 80% going home pathway 0 here at Bournemouth with the additional therapy services. And that's just iterating what I said there, the observations. And we continued that. Level 2 patients, ITU length of stay, ward length of stay, hospital length of stay, and then Bournemouth here with the additional services with a median reduction length of stay in hospital by 5 days. We saw a similar pattern here with the pathway 0 as an increase of patients going home pathway 0 in comparison to Pool. Emergency op patients, half a day difference with additional therapy service out on the wards. So it's painting a picture that the additional service rehab therapy we provided wasn't having a dramatic effect on the patients when it comes to length of stay in hospitals, which is a bit sad if you're a therapist. So we had more questions to ask on top of it. So we had a trachea patient, similar length of stay, 42 days, and a dramatic difference in pathway 0. So when it came down to hospital length of stay, there wasn't much of a difference. We looked at the overall data. So we asked some more further questions of how could we enhance the additional therapy service we had here at Bournemouth. So we took an additional 6 months and we implemented some changes. The main change we made was we provided patients who stepped down increased input. So we had a median input per patient of 2 extra sessions on the wards, and we increased that to 5 extra sessions in the wards. We introduced a standard operating procedure, so we structured our approach to how we see patients and when we see patients. We introduced a prioritization system, so actually having a system as to who we're going to see and why, and we introduced morning communications, so we were actively talking to the wards and talking to them about when we're going to see them, why we're going to see them, and working with the ward staff to try and optimize our approach to rehab for these patients. And here I'm just highlighting. So we had a similar capture of patients from 40 to 49. So what changed when we had a look at this data? So in these graphs here, we're going to have Pool, and we're going to compare it to the new 6-month enhanced rehab after critical illness. This is with the increased therapy input, the standard operating procedure, prioritization, etc. So this is our old graph. So this is our old patients of median length of stay for trachea patients, median length of stay for emergency ops, and so on. And this is what changed when we look at the length of stay for these patients with enhanced therapy. So we had an overall reduction in length of stay across the board for all of the patients. And when we compared the discharge outcomes, we had 80% plus going pathway 0. We managed to retain that above 80% pathway 0 patients going. So we had no loss of drop off in pathways. We had a reduction overall hospital length of stay. So when we look at all the graphs together, here's the original Pool data set looking at the overall length of stays for ITU, ward, and hospital length of stay. This was the initial 6 months with the 2 additional therapy sessions out on the wards. And this is the increase by 2.5 times therapy sessions of length of stay in hospital. And we can see here the overall reduction. And it looks to be roughly about 10 days, roughly, 9.5, 10 days. So we looked at costings, and this is taken from the NHS costings. We're looking at cost per day per bed. And we look at the average cost. This is based on the median length of stay in mean for Pool patients who were receiving follow-up therapy services. And this is the enhanced recovery. So this is our enhanced RACI patients. So our average patient who came through on the follow-up service with more therapy costed £14,500 as opposed to £23,000 in Pool. And this is a reduction from a reduced length of stay. And these are observations. So the reduction of almost £10,000 per patient per admission. And if you look at our population over 6 months to 49 patients, it works out to about £460,000. Or if you like my kind of math, I just round up to £500,000. It sounds a lot better. So costing service, some people really like to know a bit more what would sort of cost in a year and a bit more, I guess, future projections or ideas. So if you use a little bit of physio math and you kind of do your 49 times by 2, you're in the ballpark of 100 patients per year who are stepping down under that criteria, receiving additional therapy services. And each one of those patients is having a reduction of £9,000 from being in hospital for about 10 days less. It's an estimated saving of just under £1 million. And the current staffing we achieved those numbers was a part-time band 6 borrowed OT and a borrowed TA essentially. So some things to consider here at Paul and Bournemouth was our capacity to demand mismatch. So when we actually looked at the data more in depth, these patients actually missed 7 potential sessions if you count the weekends. So they didn't actually receive additional therapy for every single day. So there was a missed opportunity to really optimize their rehab. There was a missed opportunity there. Here at Paul and Bournemouth, we're going to merge ITU sizes. So we're going to absorb more beds, but our staffing might not necessarily increase. We don't expect this consistency to stay there. And we're going to have an increase of rehab after critically ill patients. So, and because we absorb different staffing levels, we're going to have a reduction to our services here. Somebody had asked me in the past, what would the ideal rehab after critically ill team look like? So if anyone's interested, in my mind, at least from a therapy perspective, specifically for physio and OT, there'd be some sort of a clinical lead, either occupational therapy or physiotherapy. They would have 2 registered clinicians of senior staffing of OT and physio, and they'd have some sort of a supporting therapist of a band 4 tech to carry out this rehab as well. And if you look at the costings, all mid-level, it'll work out to about just under £200,000, and this is at mid-level for all those things. And it would mitigate some of the reduction capacity, the capacity demand mismatch. It would be able to capture a wider population of patients, so you can expand your inclusion criteria. You have reduced strain on IC therapy. So we found here at Bournemouth that the borrowing of TAs and OTs pretty much came at the staffing levels, and the clinical lead essentially allowing that to happen, which we're very grateful for. And hopefully with a dedicated team, you can have continual reduction of hospital length of stay. And hopefully here at Bournemouth, if this is possible, then you can be a regional and national leaders in Raki as well. Hopefully every team would want to strive to be the national leader or regional leader at least. So off the back of all of this work that was done, what was really good, we had a correlation with reduced length of stay that hopefully you could all see. And we saw that across all subgroups when we looked at Paul and the initial Raki service. When we introduced the enhanced service, we had a further reduction of length of stay across all subgroups as well. And we had a greater correlation to do with pathways who were discharged, so going home independent or just community therapy, no packages of care. What was really encouraging was this was consistent with some work done not too long ago over at Bristol. They had a similar approach. I think the work that was done, if anyone here is familiar with the work, but they essentially randomized patients who had extra sessions of ward for a set number of time. They gave them extra therapy session. They found that overall on step down, they went home 10 days sooner as well. So there's some consistency there with having dedicated therapy input with reduced hospital length of stay. And we found the biggest impact was on our level 3 patients in trachea. So those who had tracheostomies and intubated for more than 3 days had the greatest reduction. So here's our level 3 patients. At Paul, you can see the median length of stay was 29 days. Our initial therapy service, our follow-up service, had a reduction of 1 day, and then the enhanced service had a reduction to 17 days, so 12 days reduction, which comes at cost savings, which I mentioned before. What we found really thought-provoking, and people might, I guess, point out there's a small sample size, 40 patients, 49 patients isn't your big 1,000, 10,000 patient randomized control studies that people love, some of the gold standards. We felt we mitigated that with some of our non-complex patients and complex patients, but doing median averages. So hopefully you can see these statistics are somewhat potentially usable or interpretable with the median average as opposed to just the means. And the heterogeneity of the samples. I know it's cross-site working and within the hospital, but when we looked at some of the severity illnesses, age, and sex comparisons, they were quite comparable. So if you look at the ICONARC data and the Apache scores across the subgroups, they were quite comparable. There wasn't much of a difference at all, maybe half a point between them. And the main thing here was some of the capturing of delirious patients. I think it probably gave us delirium trying to set through some of that, which is why we kind of excluded it. We found the integrated reliability was a little bit sketchy, as I like to call it. It's very medical. Looking to the future, we're going to continue to fine-tune the service, so increase into the ward team education, so trying to get them more familiar with the service, try and have them expect us and set the standards there. we want to have all our platforms online. There's a bit of a transition going from online work from ITU to paperwork based on awards. We're trying to streamline that, make it less clunky. And we want to try and look to expand to do patient reported outcome measures. And that's on step down discharge for 4 weeks, 3 months, 6 months, and 12 months. So I guess the approach we took, having it more cost based, was trying to make it a bit more, I guess, palatable to the seniors who hold all the money in the trust, so to speak. And we're going to continue to do multi-trust collaborations. So this is a few months ago now, but Southampton Hospital came down. We shared some ideas. It was quite a lot of fun, actually. We made some implementations off the back of it. So it's really good to continue to collaborate with other trusts and see what everyone else is doing. And ongoing discussions, I just said. So thank you very much for your time. That's the presentation there. If you have any questions, I'm more than happy to answer them now with Jen. And you have any emails, feedback, questions, thoughts, by all means send them, and there's my email. Thank you very much. And then stop.
No, that's fantastic. Thank you very much for that talk. Really interesting, and well done to you all for gathering that data. It's really hard to get decent data on the value of rehabilitation, which we all perceive, but we all have trouble putting a figure on. So so well done to you and your team for actually putting a figure on it. And thanks very much for that really interesting talk. So let me just go to some questions. So Emma, question from you.
Hi there, can you hear me okay?
Yeah.
So we are from Southmead Hospital in Bristol. We've got some physios and speech therapists here. We're quite a neuro major trauma heavy unit, and obviously we think of rehab as the MDT. I was just wondering where you guys included dietitian or speech and language therapy in your rehab or therapy research at all?
The short answer will be no. The sort of long answer was we would have worked in close relation to those members of staff out on the wards if they were needed. So there was some working within them, but as far as the dedicated rehab after critical illness team, it was PT, OT, and TA.
Okay, cool.
Emma,
hopefully, go on, Denise. Hi.
Oh, sorry, I was just going to add in. I'm Jen. Hello. Nada was doing all the work. There's actually no funding at Bournemouth or Poole Hospital for dietitian or speech and language therapist as any part of the critical care MDT, so we couldn't bring them into this. Yeah.
Yeah, okay. Yeah, I think that seems to be some themes. Great to hear that you were really well funded from GPICS for physio, but yeah, I think we've still got a way to go, haven't we? But hopefully this sort of research proves rehab from a PTOC point of view, and hopefully then that paves the way for more other MDT rehab as well. Thank you so much. It was great.
Thank you. Denise.
Yeah, thanks, Nada, and thank you, Jen, for presenting that. Really interesting. I had the first version last time around, and actually it's great to hear the extended work you've done since we last spoke. So that's fantastic. Just reflecting on Emma's comment as well with regards to SLT involvement. Were the tracheostomy patients decannulated on ICU, or were they managed on the ward with trachees and then decannulated later down the line?
Jen?
Shall I go? I'll go. So I think all of these patients were decannulated on critical care, but that's probably a secondary story, isn't it, around how the wards can manage the manage tracheostomy patients in the long run. I think we had the occasional, so we excluded any of the neurological patients. We had the odd neuro patient that may have ended up on the ward and was decannulated on the ward, but for this purpose we excluded them.
Okay, great, thank you.
Can I ask a question, actually? I don't think anyone else is waiting. So what you've done there is you've increased the separation between not having the rehab and having the rehab by introducing this enhanced group. And in essence, what you've done is you've proven like a dose response relationship, which is really important in these kind of studies, because if you get more of the same, you get more of the outcome, and you've proven that you have. So I'm guessing people might be interested to just hear a bit more detail about what constituted ENHANCE. Can you expand on that a little bit?
Sure. So the I wonder if I can.
I appreciate it was on one of your slides, but
yeah. So can you see it now still?
Yeah.
Yeah. So what would have constituted the ENHANCE in this case was the increase of contact time out on the ward. So giving patients more contact time and more physio sessions or therapy sessions, OT or TA sessions, really underpin the majority of it. So can we spend more time seeing patients and get them up and moving or trying to strive for their goals? A SOP was, I think, also fundamental in our approach to how we see patients. So taking the approach of they're a step down, we're going to go see them when we can, was okay, but having a structure as to why we're going to see them and having a criteria as to when and how we're going to see them was also key here. And communicating with the ward staff. So the ENHANCE aspect of it was essentially having a second layer of thinking as to why we're going to see these patients. So if we step them down with goals and we see them on the wards, we have to then work with the therapy staff who are then seeing them on a daily basis to try and optimize their goals and work in line with them. Sometimes the rehab wasn't following in line with what the ward wanted. So if we can streamline our approach with their goals, they're probably going to go home quicker because we're not having ineffective goals and management of that patient. We're becoming an extension of the therapy team. And the prioritization system was essentially utilizing our therapists a bit better. So if a patient was seen yesterday by a senior physio, it was unlikely they would need another physio to go and see them the next day. We could use that senior physio to go see a patient who wasn't reviewed in the past 24, 48 hours and utilize our skill sets in a more efficient way. So that was the ENHANCE aspect of it. And it came off the back of the RACI program taking flight, essentially. So it's not that it was anything special. It's just a natural progression of, I guess, mistakes or key points that we discovered as we went along. It just grew naturally into what it is.
Yeah, thank you. And just before I come to Ruth, so just looking at your median number of sessions there, it looks like it's, even with the ENHANCE, it's looking like it's Monday to Friday. Did ENHANCE tend to include weekends as well, or was that a bit more sporadic?
So our follow-up service didn't hit any we didn't do any weekend working. So anything, when we looked at our notes, anything that said RACI, it would have been purely Monday to Friday and not Saturday and Sunday. So we managed to give patients, essentially, if they're in for a week, we gave them a full week's worth of rehab on top of what they had in the wards as well.
Great, that's really helpful, thanks. Ruth?
I'm just under Tim, one of our consultants' accounts. Sorry, just confuse you. But I just wanted to ask, with the number in your slide there, the mean number of sessions, was that per week?
This is that mean number was in relation to their hospital stay.
I think we shall I jump in, Nada? We had this idea that we would provide additional sessions until the point that they had either met their goals or that they were essentially as independent as we could get them, or they could continue with their activities just with a couple of days a week from a TA, for example. So we just had the idea of get them to a point where they're near enough independent or near enough at a point that they've achieved all their goals, and then we would step back from a RACI point of view. So sometimes the patients would still be in hospital a little bit longer, but we weren't seeing them. They were just waiting around for surgical reviews or stoma care or something like that.
So were you seeing a couple of times a day or once a day or during the week? I think that's what I'm trying to ask.
During the week, it was potentially 3 times a week. It could have been 4 times a week. It was definitely not more than once a day, though, because the ward team might have picked them up in addition. So a lot of the patients, what we haven't captured as part of this is how many sessions those individual patients had as part of the ward teams, because I think that data would have taken us down a completely different mindset. So this is purely just based on what we were able to offer. And then in terms of the ward teams, they may have offered a little bit extra as well. But yeah, what you can see, I think, Ruth, is that there's really not that much additional input that we're providing in the grand scheme of things. You know, an extra 5 sessions in a critical care or a patient who's had a critical care stay isn't a huge amount at all, really, but the impact it has is really, really big.
Thank you, and thanks for presenting. Great presentation and project.
Thanks, Denise.
Yeah, so just to expand on things from the point of view of anyone that hasn't been present at our Southwest rehab meetings, we've been talking about this type of service in the last couple of meetings that we've had, and that included some data from the RUH, actually, from one of their medical physiotherapists who'd actually audited the length of time that it took for critical care patients to get assessed on the ward after step down by the ward therapists, and I think on average that worked out to be something along the lines of I think 5 days before. So there's that kind of lag period from they're getting rehab on ICU, hopefully doing very well and progressing, and then there's almost like a barrier that stops when they get transitioned onto the ward. And so I think a service like Raki actually helps that flow, so they don't lose that continuity, and so that it's almost like they're continuing their therapy on ICU despite wherever their bed happens to be placed. So I think that was quite shocking data when they fed that back to us, to say, actually, these patients are they do have enhanced needs. We need to flag to the rest of the hospital that they've got enhanced care needs, a bit like stroke. You know, we all know the importance of providing stroke therapy to stroke patients. It's the same with critical care, and I think it's just getting that importance of, like Jen and Nada said, it's not actually that many contact sessions, but just keeping that continuity. And if we can get the timing right, then everything else follows in terms of, you know, improvement in their functional outcome and reduction in length of stay.
Thanks, Denise. I'm going to ask you another question, if I may. Do you think the difference with the trachea patients was obviously the most significant, was my take on your data? It was kind of a particularly standout difference with the trachea patients. Do you think that is just a marker of the increased debilitation that trachea patients end up with, sicker, weaker, longer on ICU and so on? Or do you think there's something about a trachea per se that is, you know, that you assist with?
I think it's probably a bit of both, isn't it? I think that, yes, you definitely have those sicker patients, but I think that there's probably, from a rehab perspective, there's probably a greater difference in terms of what you're doing with them. So your therapy time, maybe you spend a lot more of your therapy time doing things like weaning with those patients. I don't know, really. The trachea, the data size obviously isn't very big for the tracheostomy patients, and I think it's difficult to draw that many conclusions from it, because it was only a handful of, you know, really, really tiny subgroup. And also you have really different practices in tracheostomy management. So I think that the rehab probably is relatively similar in most places, but I think the tracheostomy management is quite different. So I don't know.
The data set was, I think, maybe the biggest set we had for over a 6-month period that we could have included was, I think, 7 patients or 6 patients. So yeah, take that data with a grain of salt, because it's a very small sample size, and yeah.
Great, thank you. Any other comments or questions from anyone in the audience, particularly therapists? What do you do, or what do you don't do? What do you want to do? Has this given you any ideas? Please.
Yeah, we've had a fair amount of conversation in our regional groups. What this has done is sparked a benchmarking review nationally. So I've contacted units nationally to find out which units have any sort of similar kind of, it's almost like an outreach, like a rehab outreach service. There is a handful of units in the country that have some exemplary staffing to support this, but they've got fantastic data. So I'm hoping that people know where to reach out, because we've had, I know that Nada's very kindly spoken to Colette and Caroline before she left at the RUH. I know that we've got some pockets in the southwest, but I think, you know, there's lots of room for progression of this kind of model in our region, but also nationally as well. So there has been lots of chat. But it's been great that this was sparked up by you guys, really. So thank you.
Yeah, completely. And thanks for taking that on. Mark.
Yeah, sorry, I was going to sort of comment along the lines of what Denise was saying, that we're trying to get together. But I think it's a good example. And obviously I had the presentation from Nada before, I think, the enhanced data, and that shows a definite improvement compared to the last presentation that you gave us. It's just the power. I think some of us are starting from a point where we're nowhere near GPICS at the minute. So the thought process of trying to put in a service outside of ITU is sort of miles away at the moment. And I think, but actually the data gives us power behind sort of demonstrating the benefit of actually delivering the therapy on ICU as in the first place, and then moving it to the ward level. So I think it's using all this really for us to put in those cases for our local units with regards to improving resource to deliver what we know works best. That's just an opinion, really.
Mark, I think it's really interesting that you say that, because Nada's gone off to do trainee ACCP, and I've actually left that post as well. And I do wonder whether this service will be one of the first things to go in the financial climate. Which is such a shame, because I think that it's so powerful, and what it's saying is so incredible. But if the pressures are on the ward and you can't run the day-to-day, then this is almost, I don't want to say it's a nice add-on, because I think it's an essential add-on, but I do think that it would get questioned. So yeah. I can absolutely understand where you're at.
Yeah, no, and I think that's the difficulty, because I think from a recruitment retention point of view, if we had these services, we'd probably retain more therapists, particularly in this area of practice, because I get a feeling in order to move on, a lot of our therapists, me included, have looked at ACCP roles or that side, which takes away, depending on how they're run in different units, takes you away from the therapy aspect of care. And I think that was always sort of the worry with that side of things. So yeah, there's probably an element of looking at, I guess, whether we're talking to Denise with the other services that we're benchmarking against, as to the recruitment and retention element, where they have got these services, actually is recruitment or retention a lot better, to have that continuity of service. But yeah, you know, the NICE guidance, etc., was talking about rehab on DCC, rehab on the wards, and then thereafter. And I think probably what we're finding locally is that ability to demonstrate sort of the post-intensive care syndrome, or often it sits in community that sits outside of our organization, but actually the greater impact we have is whilst they're with us, and it's being able to demonstrate that to the wider sort of ICB program as well. And I think that's the midst of where my thought processes are.
Thanks, Mark. Out of interest then, how's this gone down with the management at University Hospitals Dorset? How's this sat with them?
I mean, it's the same with anything, isn't it? So it goes down really well and they really like it. But so I'm just trying to think of how I can diplomatically say this.
Yeah, we're recording. Just
yeah. So even though you can prove that there is a cost saving and a benefit from having good quality leadership and a good quality service, there's a lag into how that translates into actually funding the posts. So there's this kind of like, yes, this is all great, it's been presented at the trust, everybody loves it, wonderful, But then how do you actually convince somebody who holds the money that you need to invest in therapy staff to help length of stay? And that goes for the entirety of NHS inpatient care. How do you convince someone that therapists will help you reduce your length of stay? Because you can prove it, because we've proved it, but that doesn't mean that you're going to get more money to do anything about it. So yeah, I don't know.
Emma's going to give us the answer. Go on, Emma.
Yeah.
I'm really not, I'm so sorry. But I do wonder, because I guess you the project's fascinating and the numbers are great, but I guess you've acknowledged that it's a small sample over actually a really short period of time. So I think to some extent you've got no choice but to carry on. I know it's not going to be you guys, but that data needs to carry on being collected, because whenever it comes to the management being persuaded to invest, they need to know that they're paying on a recurring basis. They need to make sure that those benefits coming back in are also going to keep going and keep coming back. And then I guess you could also get to the point of checking with them, okay, well, this is how I'm presenting the data to you at the minute, but actually, is there another outcome that talks better to you and to your purse strings? And that's almost probably going up another level to another level of management, and just maybe tweaking the data collection accordingly. The other thing that I found really helps is pulling the heartstrings a little bit. So getting some more qualitative and some patient feedback, feedback of how it's helped the wards manage as well. If you're coming in supporting these patients, what is it then allowing those ward staff to do in addition to what they normally would be able to do? So I think there's lots of extra bits that could be added to help.
Yeah, I think hopefully one of the guys who still work at RBH and the team are on here and they can take it forward.
Yeah, some really good points there, Emma. Thank you. Well, thank you very much to you all, and thank you for those of you who've joined in the discussion. That was a really interesting project. Well done for collecting that data, and yeah, I hope, as Emma suggests, I hope that data collection is ongoing, and because it appears really valuable. I think there'll be therapists across the region who'll be really keen to see any further data from you guys. So thanks again, and thanks for taking the time to share that with us.
Pleasure, thanks for having me.
Thanks so much.
Okay, we're going to move on to the last talk of the session. I'm just looking through the attendance list. I'm not seeing that Tim Cook has joined. So micro pause while I Tim's having some IT issues. He can't get into Teams, but he's trying again. So hopefully that it'll just be a couple of minutes. Okay. Any thoughts or comments or questions on the talks we've had already? No. Okay, good. All right. I'm going to start to introduce Tim. In the hope that he joins any moment. So Professor Tim Cook, he's a consultant in anaesthesia and intensive care medicine in the RUH. He holds a chair at the University of Bristol, and he's been the lead for all of the national audit projects, which have been run by the Royal College of Anaesthetists over the last few years. He is prolific in terms of research and writing, and between him and Jerry, they're basically the two reasons why the RUH is the third most research active hospital in the world. So I'm really grateful to him taking the time to come and talk to us about the thing that he's probably most passionate about, which is airways. So we'll just have a pause until he's joined, but there we go. So Tim, I think you're in now.
I think I am, yeah.
Yeah, okay, grand. Well, welcome. Thank you very much for taking the time out of your busy schedule to join us. I have actually introduced you already.
Super, yeah.
Which of course means that you didn't hear the introduction, but I can promise you it was generous and accurate.
I'm sure it was more generous than it needs to be.
Okay, brilliant. So, Tim, I'm going to hand over to you. Thank you very much for taking the time to join us.
I'm just trying to get the right screen shared, which isn't at the moment. Try that one. Right, are you seeing my screen yet?
Yeah, that's it.
And I've got two screens, so it'll now go on to either you seeing my shared slideshow or just the one screen.
That's it. That's just the one screen. That's perfect.
Correct?
Thank you.
Okay. Right. I'm Tim Cook. I work in Bath. And I'm going to talk about airway matters, which really, firstly, it's a pleasure to speak. So, as I say, a couple of minutes late. It's a big subject, and I won't be able to cover everything by any means. And it seems to be moving forward quite slowly. I have no financial conflicts of interest. You can read that information if you want, but I assiduously have no financial conflicts of interest. I'm going to warn you that I'm going to talk about a couple of things early on that are quite sensitive, might be specifically sensitive to some people on the call. I apologise if they're sensitive, but these things have to be aired. Airway management occurs in every intensive care throughout the country all the time, and problems do arise. And I'm mainly going to talk about problems that arise and evidence-based ways of working around it. And I'm predominantly going to talk about intubation and management of the critically ill intubation, but I'm not exclusively going to talk about that. So the ICU airways, traditionally we've talked about the anatomically difficult airway, but we need to move on from that. We need to think about airways that can be difficult physiologically, which is particularly in the intensive care. So airways where the anatomy may be easy, but managing the airway comes with it particularly difficult problems, particularly hypoxia and cardiovascular collapse. But in addition to that, we have logistical difficult airways. Anyone who works in Bath or any of the older estate intensive cares in the NHS will know that getting to the head of the bed is a big challenge. That's the first big challenge. There are other challenges such as support from experts, having the right kit, and also having the right knowledge, which I'll come to a little bit later. And so we have logistical and educational difficulties. And I think probably anatomical difficulty is the least of the problems on intensive care. Although, of course, we have a more comorbid and more obese patient each year. This is a case from 2015. It was a death in a hospital in the southeast. A lady was postpartum, came to ITU with pneumonia. She had a rapid sequence induction because of progressive hypoxemia, and she had 5 attempts at laryngoscopy. The first attempt nearly saw the vocal cords, and progressively things got worse and worse until there was no view, and having been easy to ventilate, the patient became difficult and then impossible to ventilate. There was hypoxemia. An attempt was made to rescue the airway with a classic LMA, which failed. There was cannot intubate, oxygenate, so airway failure, a delayed and failed front of neck airway, and the patient died. This went to court, and there were significant discussions around it. But I think it's typical of airway disasters. So airway disasters usually start with an ability to oxygenate, an ability to ventilate, and almost an ability to intubate. So you can nearly see what you want to see, but you can't quite see it. And there are multiple attempts, often by multiple individuals. Attempts variably to rescue the airway, the supraglottic airways, often with the first generation supraglottic airway, and a slow transition through the guidance pathway. Deterioration in ability to oxygenate and ventilate the patient, and eventually the need to perform a front of neck air, which may be unrecognised or delayed, and unfortunately sometimes inexpert attempts at ePhono. So getting things right first time is important in airway management, arguably more important than anywhere else in medicine. And there's very good evidence from pre-hospital medicine, from the emergency department, from ITU, through anaesthesia, everywhere, that with increasing attempts at intubation, there's an increased rate of complications. Now, of course, patients who are more difficult are going to have more attempts. So there's some confounding in that. But there is also greatly acknowledged that multiple attempts lead to multiple problems. So this is the typical event which happened with OO, and a couple of things to comment on. So this isn't very modern or very excellent airway management, I would say. She had 5 attempts at laryngoscopy. None of them included video laryngoscopy. There's a video laryngoscope sat in the corner, not used. The first intubator assumed that it had been used by others, or didn't want to use it, and beyond that, it was assumed it had been used. A classic LMA, a first generation supraglottic LMA, is never going to rescue a postpartum patient with pneumonia and congested lungs, poorly compliant lungs. And there were delays in ePhono while the staff on ITU waited for ENT to arrive, and indeed waited for an ENT SHO to arrive. I believe in court, and I'm not sure this is true, but I was told that there was a statement that the DAS guidelines didn't apply for the critically ill patient, and therefore a clear knowledge of them was not necessary. Some deaths from airway management are avoidable, some are not. Allowed to draw your own conclusions. And I think, having described that anatomical difficulty, that physiological difficulty, logistical and educational difficulty, the patient presents with anatomical and physiological difficulty, which we need to manage, but we need to either eliminate or organisationally manage logistical difficulties and educational difficulties. And I think there are educational, logistical difficulties there in addition to any physiology or anatomy. Just to make it more pertinent, and in the last 2 years in our region, I'm aware of one airway death during tracheal tube exchange, an intensive care patient going to theatres. I'm aware of another intensive care patient who very nearly died, again from severe barotrauma during a tube exchange, and I'm aware of a death from unrecognised esophageal intubation. This is that death. I'm not wishing to offend or upset anybody, but these cases have to be discussed. You'll notice that from there's very limited reporting of this case, but it was reported only as gifted student dies from adverse reaction to medication. If you read through the actual report, it reads that central to that were critical errors during medical intervention and an erroneous intubation procedure. Joseph died of esophageal intubation. I'm not going to go through this, but esophageal intubation is a complex process. I think these are the situations that happen. An erroneous belief that intubation has happened, a flat or abnormal capnograph, and then human factors take over with people believing the tube is in the right place, a clinical crisis, calls for help, a difficulty in managing people, and an over-reliance on belief that the tracheal tube's in the wrong place. Most of these cases are not difficult intubations, although in this case there were certainly compromising factors in that. We need to do better. There are now guidelines for managing that. But airway management in the critically ill patient, so not just in intensive care, but the critical ill patient is ill. We have these eminent people, Jerry and Fiona from Bath, who 10 years ago wrote this article and summarised airway challenges in critical care. It was a narrative review. It was not systematically put together. But if you look at these multiple attempts, severe hypoxemia, severe hypotension, esophageal intubation, aspiration, cardiac arrest. Before I put the numbers up, you can think about what you think those relative rate, the frequency of those events are going to be. And from those studies at that time, more than 10% of patients having more than 3 attempts, 7% severe hypoxemia, almost 20%, almost 1 in 5 severe hypotension, 5% esophageal intubation, 3% aspiration, and 2% cardiac arrest, so 2% dying without resuscitation. NAP4 in the same year looked at this same topic, and NAP4 was a national registry of airway complications that led to death, brain damage, or emergency front of neck airway. And of the, although we only had coverage in about half of UK hospitals, we had almost 20% of events occurred in hospital. And although 36 events occurring in a hospital doesn't sound, in the country, it doesn't sound many, but these are complications of airway management leading to these very high poor outcomes. And if we compare the rate of these complications in intensive care in the emergency department to anaesthesia, we'll see this. So of the cases that were reported that met criteria, if you reported a case from anaesthesia, 1 in 7 of the patients had death or brain damage as their outcome. In the emergency department, it was 1 in 3, and in ITU, it was more than half. So if we try and compare the incidence of these events, so if we look at the number of cases, death and brain damage from anaesthesia on the left, and we have a denominator of about 3 million anaesthetics, we can see that the incidence of these events leading to death and brain damage is around 1 in 180,000. We can call that rate 1. If we look at intensive care, where there are about 60,000 intubations done, in the emergency department, where there are 20,000 done, and use the numbers of cases we had in NAP4, we can see that the rates of complications are more than an order higher in magnitude than in anaesthesia. So we're dealing with a very difficult situation. 40 to 60 times higher frequency of death and brain damage, and that's up to 1 in 3,000 cases in intensive care. This is 11 years ago. But not only are those cases more common, but they were associated, because every case was reviewed, they're associated with greater gaps in the quality of care that was delivered. So poor identification of at-risk patients, poor planning, inadequate staff and equipment, delayed recognition of events, failed rescue, and a lack of use or failure to interpret capnography. I think things have moved on, but these are avoidable deaths, and I'm afraid they probably still occur. I'm just going to jump through those. Is it still happening? So this is the most recent pragmatic, in real life study of a large cohort of patients having tracheal intubation. It's international, so it covers 30 countries, includes some low and middle income, but mainly it's high income countries, and 3,000 patients. It's a registry, so it gives us real life information. And they looked at effectively 3,000 intubations of critically ill patients, and wanted reporting of the incidence of severe hypoxemia, cardiac arrest, and cardiovascular instability defined as stated there. With those secondary outcomes, other complications of airway management, intubation. And essentially, they were looking at about half of the patients were having standard option therapy, and about 30% had significant respiratory failure. About 50% of the patients were intubated for respiratory failure, which would probably be in keeping with most people's practice. There you go, 52% was respiratory failure and 30% neurological failure, and 9% cardiovascular instability. So there's a mixture of high and low risk patients there, most of them on an ITU, most of them urgent, and half of them intubated by residents, of whom half were anaesthetists. And that's, I think this is a sort of in real life representation. And you can see the rates of complications. So overall, of those first primary outcome complications, almost half patients had those primary complications of cardiac arrest, severe cardiovascular instability, or severe hypoxemia. And that includes, so far and away, cardiovascular instability occurred in 43% of patients, and cardiac arrest in 3%, very similar to Jerry and Fiona's number in their previous review, and severe hypoxemia identical to their review as well. Worth noting also that esophageal intubation, recognised, occurred in 6%, a higher rate than airway difficulty or aspiration of pulmonary contents, which we spend so much time trying to avoid. In terms of the procedures which they also looked at, only a quarter of patients had waveform capnography, and about 80% of patients were intubated on first attempt. It's worth noticing that 60% of patients auscultation was used to confirm successful intubation, which is an unreliable technique. And I would suggest to you that if capnography was only used for 25% of patients at the point of intubation, for further use on ITU, it would have been significantly lesser. I'm going to throw this in there. We're going to have some questions afterwards, and I can get pilloried about this. So I'm going to tell you that intensivists are less expert at airway management than anaesthetists. And I've chosen my words carefully. The word expert is important there. And we work in more adverse settings, dealing with more difficult patients with those logistical and educational issues. And why do I think that? I think that because Aristotle tells me that. We are what we repeatedly do. Excellence then is not an act but a habit. Most intensivists do not intubate or manage the airway of patients every day, and therefore we are less familiar and less expert in those techniques. So it behoves us to concentrate very much on these high-risk patients and make sure that if there's a problem with airway management, that it's at the anatomical or physiological end of the patient, not at the logistical or educational end. I'm going to run through really quickly a whole load of evidence about videolaryngoscopy because it's a really important element. In Bath, we use videolaryngoscopy for all intubations. There has been some contention as to whether that's the right thing to do, and particularly intensive care. And I'm going to throw at you the most recent evidence. The first evidence comes from anaesthesia, this mega Cochrane review done 2 years ago by Jan Hansel and Andy Rogers, now a consultant in Bath, looking at 26,000 patients in all settings, and looking at 3 different types of laryngoscope. So a Macintosh laryngoscope, that's a fairly standard laryngoscope, a hyperangulated, so that's a glide scope or a McGrath or a CMAC-D blade, and then these channeled scopes, which aren't really used very much in the UK. And the summary of the evidence is that whichever device you're using, so for anything that's green here was statistically significant. These are all the point estimates, and the orange is not statistically significant, but the point estimate favours. So everything favours videolaryngoscopy. higher rates of first-time intubation, less hypoxia, less failures, less hypoxia, higher rates of first-pass success, fewer esophageal intubations, better views, lesser dental trauma. And there's a wealth of evidence that supports things elsewhere. So this is anaesthesia. And I can offer you this. I can offer you a device that reduces failure, especially in the hands of difficult patients and in trained operators. That's other evidence. Makes laryngoscopy easier, reduces poor views, improves excellent views, improves fast per success, reduces hypoxemia, reduces esophageal intubation, reduces laryngeal trauma and patient sequelae. Do you want to use it routinely? Or I can offer you the opposite, and maybe you should ask your patient which they want to use. Do we have evidence in the critically ill for the benefit of video laryngoscopy? Can we translate the evidence from anaesthesia to ITU, ED, and pre-hospital medicine? I think most of the studies, the randomized controlled studies that exist, are looking at the efficacy of the devices. So they're looking at whether the kit works, and I think by and large they can. They're not very good at looking at high risk settings because anaesthesia is lower risk. There are quite a lot of studies, problems with the studies in the critically ill, and I've listed them there. So the specific setting, the fact they're often very small, there may be variation in preoxygenation, paralysis, sedation, particularly across continents. Many of the studies will exclude difficult patients, and the devices used are very variable. So there's a mixture. Probably some video laryngoscopes are very poor quality and don't help, and some do. But if you put all the information in together, you tend to lose the evidence, or the evidence tends to sort of gravitate to the mean. Staff come from various specialties with various skills, and there's various seniority in who's doing what, as well as experience. So, but I don't see any real reasons why the anaesthesia evidence, which I've just showed you, should not transfer to critically ill. But if we just look at the critically ill data, in that Cochrane review, Jan and Andy Rogers extracted the ITU studies, which is 21 studies with 4,000 patients, so only about 200 patients in each study, which means 100 intubations in each study, so not very big. All were at high risk of bias, and all the point estimates favoured intubation. But because these complications, such as failed intubation or hypoxia, don't occur very frequently, most of them didn't reach statistical significance. So if for those who are au fait with these things, you'll see that the 95 confidence intervals cross 1, meaning the results are non-significant. And the I-squared is usually above 75%, which means that the data is heterogeneous. So there's not a consistent message in the data. So it's dirty data to look at. That meta-analysis has now been updated by this study in critical care, which was published this year. And they have now shown, so that's another 7 studies, so 14 studies, in now a larger number of patients in critical care, and shown an improved first pass success rate, so 12% greater first pass success rate, reduced rate of aspiration, and a halving of the rate of esophageal intubation, which I'm going to come back, which suggests that video laryngoscopy is both a more effective and safer strategy. Therefore, we should be using it first up. So in terms of their endpoints, this is what they said: compared to direct laryngoscopy, video laryngoscopy significantly increased the number of successful intubations. In terms of, so the subgroup analysis sensitivity, so the CMAC and GlideScope performed similarly with benefit, but the McGrath and other devices didn't have benefit. So devices perform differently, and I have to say, I would say the CMAC and GlideScope are a step above other equipment. And then esophageal intubations, as I say, reduced. So I'm just going to dive a bit more into esophageal intubation. Esophageal intubations, in my view, are unrecognised esophageal intubations are avoidable deaths. Harm from esophageal intubation is avoidable. So this is a previous study of video laryngoscopy. For those who are not used to looking at these forest plots, then each of the lines on the right, the horizontal lines, represents an individual study, and the 95% confidence interval for that. If the lozenge is not crossing the vertical line here, the overall orange, then the overall effect is statistically significant and favours either videolaryngoscopy or direct laryngoscopy. In this case, this meta-analysis, putting all these studies together, suggests that videolaryngoscopy reduces esophageal intubation. And we looked at it from the meta-analysis that Jan and Andy Rogers led, and included 40 studies outside theatre, 40 studies in total, 11 of which were outside theatres. We were looking for esophageal intubation, not undetected esophageal intubation. But remember, if you don't have esophageal intubation, you can't have unrecognised esophageal intubation. I think this is the most important thing to find. So most of these studies will be done in by senior anaesthetists in a low-risk setting with optimal circumstances, with everything as good as it can be. And in spite of that, in these randomized controlled trials, perhaps with difficult patients excluded, in 3% of intubations with direct laryngoscopy, esophageal intubation occurs. That's reduced threefold with videolaryngoscopy. If we put all those studies together in a sort of a mega forest plot, then you'll see that the vast majority of studies, their blue dot is to the left of that central line, meaning that they favour videolaryngoscopy, and overall the lozenge at the bottom is off to the left. So there's a twofold reduction, a relative rate of 0.7. So you're halving the rate of esophageal intubation. If you look at the individual devices, there are different ways, different outcomes, depending on which particular method you use to analyse it. But in broad terms, irrespective of the device you're likely to use, it favours videolaryngoscopy, and it's almost certainly statistically significant. Just to mention, there are huge benefits, non-technical benefits of videolaryngoscopy. So supervision of trainees, allowing trainees to intubate patients who otherwise one might not wish to allow, to teach them, to give them an opportunity to allow them to persist for longer, safely and successfully. Use as a rescue tool, so that when we have to work with our difficult airway algorithms, everybody is aware how to use a videolaryngoscope and when to use it and how to use it expertly. It improves the adjustment and use of cricoid force, and it improves communication human factors. I'll come back to two-person checks in a minute. So it changes the culture. I'm happy to take questions on that. So the summary around videolaryngoscopy. The evidence is undoubted that videolaryngoscopy is more effective than direct laryngoscopy. It provides precision intubation, and it is almost certainly safer than direct laryngoscopy. And in ITU, the evidence says it is safe.